Well, good morning, everyone. Or I should say, good morning, Baltimore, for those of you who are joining us here. We did find the clip from Hairspray that we didn't play yesterday for our opening music. I want to welcome you to day two. For those of you online, it was a beautiful day in Baltimore. It's sunny. The Inner Harbor looked about as good as it ever does. So, but I want to thank everyone for joining us both in person and online. I'm Mark Solkowski, and I have the privilege for a number of years now chairing what we call day two, or the Sunday day, where we're really going to focus on viral hepatitis and liver disease. We're going to cover a whole gamut of viral hepatitis B and C, as well as metabolic-associated steatotic liver disease. And Ken Sherman will explain to you why I use that word and not fatty liver. So we've got a busy day ahead of us. So I'll get started. I've got to go through some of the housekeeping notes. So again, as I just mentioned, we're in person and virtual. We do want to keep the folks that are virtually engaged. So I'll remind you that if you're asking a question, use the microphone so that the people at home can hear you and participate in the Q&A panels. Accreditation, just like day one, we're accredited by Rush University Medical Center. The number of credits available are shown there. Further information regarding the CME is designated here for both physicians, nurses, as well as pharmacists. Opinions and off-label discussion. I can be confident you'll hear a lot of opinions today during the case presentations and the panel discussions. And honestly, that is, I think, one of the most important things here. We discuss the evidence, and then we talk about opinions and off-label discussions. But this slide is the disclaimer for anything you may hear during that panel. I'd be remiss if I didn't thank our commercial supporters shown here. We are grateful for their support and part of this conference. The in-person people get a printed copy. I know the people at home are jealous because they don't have this printed copy in front of them, but it does have all the information you need to follow the meeting. But there's even more available online. You can get the virtual brochure by clicking at that button on top of your OPMAN XXXII panel. And you can also see the slides. So as the talk comes up, you can click and see the in-person presentation slides. Virtual slide presentations are there. That last one was for you people here to use the online version. Technical assistance. We've got a fabulous technical team, both here on site to make sure everything goes well, and also to help you all at home. There is a number you can text to get information or help if you need that. So keep this one in mind. We are recording, so we do want to keep the questions confined to the question panel period. I did hear a couple cell phones yesterday go off. Luckily, it was not mine, but please turn off your cell phones, and that allows us to have a really nice conference recording for the future of the meeting. Post-conference evaluations, this will be an email that you get after the meeting for a survey, and we will remind you. So my advice is when you get that email from Lashley, just go ahead and complete it, because that way you won't get the other emails reminding you to do it. And your feedback is incredibly important for us. We do review that. Mike and I sit down with the team and we look through this and we think about what do people want to hear next year? What do we want to do? What worked, what didn't work? So please give us feedback. Long-term outcome measures. You know, our goal is to improve the care of people with the diseases we're talking about here. And many of you are frontline clinicians. We want to hear, did this have a long-term impact? Did what you took home from OPMAN help in how you manage people and improve their health outcomes? So you'll get a survey in 2 or 3 months following the conference via email. Same advice, just go ahead and answer the first one. That way you won't get those return ones. Audience response system. Hopefully folks have mastered this using their cell phones or computers. There's a QR code for those of you in person. It should be on your table. And we'll go ahead and we do have questions throughout the morning as well. And this is the archive. This will be available in early April where you can re-watch your favorite clips. I know Dr. Sag re-watches many Broadway musicals. And like the Broadway musicals, you can watch these at your leisure at home. So here's our agenda for Sunday, March 17th. We're in the introduction period. We'll lead off with management of hepatitis C. For those of you who attended this meeting know we used to have a number of sessions on hep C, and fortunately the treatments got a lot easier. We heard from Charlie yesterday about the potential promise of long-acting therapy, a one-shot cure, if you will. But we've condensed it, and we've asked Susanna Nagy to take us through the entire spectrum of hepatitis C optimal management, and she'll lead us off today. We're focusing a lot more on hepatitis B. It's a complicated viral infection. We're really thrilled to have Shamko Dalil, who is the Chief of ID at University of Maryland, join us to talk us through both Hep B and D. We'll then have a Q&A panel discussion, and then have Devika Bhattacharya join us. She flew all the way from Los Angeles, like Rafi did yesterday. We'll talk about co-infection. And the questions just never stop about managing people with HIV and hepatitis B, because it's complicated, and Devika will walk us through some of the nuances and things you need to be aware of. We then have a panel discussion. Devika and I will answer your questions. Then we have a break. Then I'm pleased to have Ken Sherman, who is going to talk about what we used to think of as fatty liver disease. Ken will explain to you why we're now using the term metabolic dysfunction-associated steatotic liver disease. It's a mouthful, but NASH has become MASH, and he'll talk through that and explain how that's impacting our patients with HIV. And then we'll end the didactic part of the morning with Glenn Treisman, my colleague at Johns Hopkins. Glenn will talk to us about managing patients with substance use disorders, and that will be a really important, interesting talk. A lot of what we talked about both yesterday and today. The substance use disorder is a major issue we need to deal with concurrently with treating the infections, whether it be STIs or hepatitis C and B. So Glenn will lead us through that. We'll have some time for a panel discussion. Then we have a working lunch. We'll do the same thing we did yesterday, run out, get some food, come back, and we'll do case presentations. We'll ask our faculty to join us up here. And then at the end of the case presentations, we'll let the people watching virtually at home enjoy the rest of their Sunday afternoon. And for those of you here in person, we've got some round tables. They're in the same rooms as as yesterday, one floor up, and we'll have roundtable discussions that will take us up until about 2:30, so a half hour. You can attend 2 of the 3, and we'll see those a bit later. So these are the sessions you have an opportunity to attend. We've got Glenn Treisman and Susanna, which should be fun. That will be an interesting one, talking about hepatitis C challenging cases. Devika and Sham will talk about Hep B and D, and I'll join Ken to talk about MASH, or metabolic-associated steatotic liver disease. You see the rooms there. We'll remind you again, you don't need to remember them from this morning. So with that, I'm really thrilled to welcome back Dr. Susanna Nagy from Duke, where she is professor of medicine and has multiple titles, including vice dean for clinical investigation. And she's going to take us through a decade, which when I saw her title, I had to count back, and I said, dang, it really is a decade of direct-acting antiviral therapy, which means a couple of things. Where we are, we're getting older, but we also are still trying to deliver these tools, and she'll take us through some of the nuances and some of the unanswered questions in 2024. Susanna?
Well, thank you, everyone, and good morning. It's great to be back in front of this group. I see so many familiar faces. You're a fantastic, long-standing commitment here, and it's always fun to engage with you all in this way. It's also, for those of you who don't know, this is back home for me. I'm a Maryland grad and went to med school in Baltimore, so it's really nice to be back in Maryland and back in Baltimore. So as Mark said, I'm not going to try to cover everything about hepatitis C in 30 minutes, but hopefully we'll talk about things that are the most relevant to where we are as clinical providers in HCV right now. My disclosure slide. So I'm going to briefly touch on epidemiology and HCV treatment approaches. Actually, Mark, my title changed when I started putting this talk together, and I realized that we were exactly 10 years into the first all-oral DAA approvals for genotype 1. And then I think really focusing on, and I'd love to hear from all of you, where are we right now? 10 years in, what have we accomplished? And how close are we to this concept of HCV elimination in the United States? And there are things happening. I think we briefly talked about this last year in terms of the White House administration actually putting out an elimination plan for the United States. And where are we, and what are some of the things that are coming out of that a year later? All right, so quickly about epidemiology, and much of this is something that you have seen before in prior slides, but just as a reminder that right now where we are, and this is really driven by new cases in this kind of biphasic chronic infection epi that we see. I think we knew historically that, that people from what we've called the baby boomer population had carried a significant amount of the burden of HCV infection kind of when I started doing this. But this has changed significantly, and I think we'll talk more about this, but the cases in our younger people are also the cases that we're seeing in acute infection, so not just chronic, and we're also seeing that there is actually a bit more of an increase in the representation of women in this population. And that does play out to be really important as we think about transmission into babies. So we still are at a point where the estimates, the most recent estimates by the CDC, is somewhere close to 2.5 million people in this country living with HCV. And the other issue is that the recognition most recently is that at least 40% of those people still to this day do not know that they have chronic hepatitis C infection, which means they probably also don't realize that they have an infection that can be cured. That's a pretty big challenge for us. And again, I think we saw this slide last year, and as I mentioned, if you look at this, and I think I actually may have this already made, but it's this younger generation, it's really the millennial generation where we are seeing these increased cases. And you could argue that you see increased cases really across the board, but the reality is that we're seeing this in younger folks who really are between the ages of 20 and 40. And we're gonna end with this, which is, if that's the case, how do we get these younger people into care and into treatment? And I know we referenced this last year. We're gonna have to do something different if in fact we're gonna get a handle on where we are with the epidemic. Just mentioning this briefly, given this younger age group, and given that there is an increased representation of women or people who could be pregnant, we are seeing that this is playing out in terms of risks to newborn babies with regards to HCV transmission. And we are seeing reports of increased transmission compared to what we really thought of historically. And I don't go into great detail about pregnant people and treatment for pregnant people, but we could certainly maybe have that as part of a conversation as we move forward. And potentially it's a case, I have no idea, but maybe. So I was a little bit embarrassed when I saw the slide, and I said, I'm glad I changed this slide slightly from last year. But it's a good reminder that the WHO has identified goals for elimination. In fact, they've recently changed them to incidence goals, which I feel like are very difficult to consume. So I've tried to keep them the goals that were set forth before they moved to incidence, which is really looking at, decreasing the incidence of new infections. By 2030, we need to be at 90% reduction in incidence. 65% reduction in mortality. We need to ensure that 90% of people by 2030 in this country know that they have HCV infection. And as I mentioned, today we are at 40%. And then also, once they know that they have the infection, we need to ensure that at least 80% of them are being treated. And I'm going to show you numbers for where we are in this country today, 10 years into the pandemic, or into the epidemic, and we're not there. So these are updated numbers from what I showed last year, because the CDC has recently updated these numbers through 2021, as you can see here. And similar to last year, we are good when it comes to liver-related death. And this is likely driven by the fact that we do have about a third of people in this country who have been treated for their hepatitis C, and that very directly means decrease liver-related events and therefore decrease liver-related deaths. But where we are really in trouble, as I mentioned, is in this drive of new infections, which again is a group of patients and people in our community that we really need to think about how we can reach. So treatment approaches, I just put in 2 slides here just to bring this home, and you all have seen this slide before, but this does get to the 2014. And so the way I picked 2014 was that was when our first all-oral therapies for genotype 1 became available. Now, many of you may have been doing what I was doing in clinic, which was actually combining sofosbuvir and samipivir at the time, which was an all-oral option, but it was not approved by the FDA until 2014. We did have all-oral therapies for genotype 2-3, as some of you will remember, sofosbuvir and ribavirin. I literally had a patient in my clinic. He actually came into my clinic 10 years post-cure I don't see him anymore because he actually moved, but he happened to be back at the VA because he's being evaluated for a liver transplant for hepatocellular carcinoma, and he came by clinic to say hello. It was really nice to see him. It was great to see him, but I remembered that, we used to actually do, for genotype 2 patients, soft ribo, which is pretty interesting. So 10 years later, where are we? We have treatments for almost every population, I would say, with the exception of pregnant people. And that remains, I would argue, a gap in terms of approvals by FDA for a patient population that's really critical to addressing the epidemic. But we have safe therapies for people with end-stage renal disease, for people who have had a transplant, for people with decompensated liver disease, and for people who have failed first-line therapy. And we have very active and effective salvage therapies. As a quick summary, and just thinking about where we are in terms of the guidelines. There are basically, if you look at the guidelines, currently the AASOD IDSA guidelines, there are essentially 4 regimens that are recommended at some point in the guideline. Although the reality is most of us are largely using 2 of those options because they're pan-genotypic, right? So for pan-genotypic regimens, we have 2. As a general summary for this slide, we have 3 drug classes, right? We have the NS3 protease inhibitors, we have NS5As, and then we have an NS5B nuke. Generally, first-line therapies for people who are treatment naive and never treated and have never failed a DAA regimen is really a combination of 2 of these, either an NS3 protease with an NS5A or an NS5A with the nuke. If someone has failed a highly active DAA therapy, then we combine all 3 drug classes. And we have 2 options for that. One is FDA approved and one is not. I think the other point that I wanted to raise here is even though we have high barrier to resistance with these regimens, when they're only used in a true drug regimen, we do not overcome the risk of resistance. And the majority of people who complete a full course of therapy, whether that's an 8-week course of therapy with the glecaprevir pibrentasvir regimen or GP, or a 12-week therapy with sofosbuvir velpatasvir or ledipasvir sofosbuvir, the rates of resistance, treatment-emergent resistance is high. The good news is a triple regimen will salvage the vast majority of these patients regardless of a resistance mutation. And that generally has played out to show that these are a triple regimen. 1 is much less likely to produce a resistance mutation, but 2 can salvage these patients who develop resistance. So where we are today, and I've shown this slide before to you all, but there have been some changes in a very positive way, is that we really can simplify treatment now. And I think we would all talk about this as subspecialists. We really complicated things for a long time. Ultimately, if we're going to get to a point of elimination where more than 1/3 of people in this country have been treated, it's going to have to be done by non-subspecialists. And that means simplifying this. I mean, 10 years in, we have a lot of confidence in the safety of these regimens. We have a lot of confidence in the efficacy and effectiveness of these regimens. So we really need to make this simpler so that providers that are in more rural areas or that are in general practice are more comfortable doing this. The AASOD IDSA guidelines have created these simplified approaches to therapy. Here I'm showing you for people without cirrhosis. Congratulations and thank you to Dr. Bhattacharya, who removed people with HIV from the not eligible list. And so you can see here that the people who are not eligible for simplified therapies are largely people who have failed a recent and highly active DAA regimen, people with active hepatitis B infection, and that's because those people do need additional monitoring because of the potential risk of reactivation of hepatitis B. Current pregnancy, we've already talked about that, or someone who had a prior liver transplant or has a known or prior hepatocellular carcinoma. You can see that cirrhosis is listed here, but that's really because you need to think a little bit more about those patients before you think about a simplified approach. And there is a simplified approach for these patients. And so I've summarized this here, but the bottom line is you don't need as recent labs, you don't need to check labs right before patients start, and you don't need to follow them for safety because we are very confident if you've given the right regimen to a patient, the risk to these patients is exceptionally low. And it's really important that we overcome some of our traditional barriers that we've put in place as providers and healthcare systems to be able to get patients to drug in hand. I think I used this term quite a bit last year, drug in hand, so that they can get access to HCV cure. So the reason I raise this is, what about people with cirrhosis? So people with cirrhosis also have an option for a streamlined approach to care. The difference is you really have to pause, as I told a fellow in my clinic last week, and calculate their Child-Pugh score and make sure that you don't see evidence of decompensation. Because in that setting, you don't want to treat those patients with a streamlined approach, and you do want to engage those patients in additional liver-related care before you move forward with the treatment approach. So what's the data behind this kind of streamlined approach? And I think we referenced MinMon last year. This has now been published and is really the largest study to support the concept and the safety of a simplified approach. This was a very large study that enrolled patients across the globe into a simplified treatment approach. So how did this work? Bottom line was there was baseline testing. This was part of a clinical trial run through the ACTG, but there was no pre-treatment genotyping. I will add, in addition, that while patients with hepatitis B surface antigen were excluded from this because, again, of that simplified approach, people with an isolated core antibody to hepatitis B were not excluded. I think that was really important because there was a lot of attention to this for quite some time in terms of the potential risk of those patients reactivating. I think we now know with very large amounts of data that this population is actually, it's quite safe to treat them with a simplified approach. All the drug was given at the same time. So this concept of having to come back for refills or get refills was something that this group really wanted to remove as a barrier, because we recognize this is a significant barrier for our patients in terms of having to either come back in and pick up those drugs or having to ask for that refill. And then there were no scheduled on-treatment clinic labs. So this was really about, here's the drug, go take it, and as long as you take it, we're gonna see you back 12 weeks after you're done, and we're gonna see whether or not this works and whether or not we can and whether or not this is something that you can do on your own, right? And I think you all know there was a check-in at week 4 just to make sure folks weren't having side effects or problems or any sort of logistical issues, and then a reminder right before their SVR12 check to come back in. And I think this was actually a really important other piece of this was, I think our confidence in using non-invasive markers to determine whether or not someone has cirrhosis has also significantly changed over this 10-year period. And that's been really important, again, to decentralize the access to HCV treatment and HCV cure. So this was based purely on FIB4. And what I can tell you is that there were not complications related to people with decompensation, for example, being missed here. Patients with cirrhosis were not excluded, obviously, but that using FIB4 to determine safety for a determination of cirrhosis did not increase risk to these patients. And I think you all know, with almost 400 participants in this trial, that the cure rate was 95%. And this is great. If you look at whether or not there were subgroups who had lower SVR rates, the subgroup with the lowest SVR rate was actually patients enrolled in the United States and patients who were younger and likely had active injection drug use. And that's why we're going to go back to this population over and over again to think about how do we get these folks in care and attempt to really get at this issue of incidence. All right, so access to treatment. So where are we 10 years in? I don't know if you've all seen these numbers, but these were recently updated by the CDC. 1 in 3 people have been cured overall. 1 in 3 in 10 years. And my guess is there's a lot of overachievers in the room, and no one's happy with this number, right? If you look at people without health insurance, it goes down to 1 in 4. If you look at people who are under the age of 40, the group that I'm talking about here in terms of increased incidence, goes down to 1 in 4. And if you combine those to people less than 40 without health insurance, it goes down to 1 in 6. So we have a problem, and it's a problem we need to solve. So I think I used this slide last year as well. I mean, this is actually a study that was published a couple years ago. It looks at a pharmacy prescription database, and it looked at where are we in terms of prescriptions. Again, if you, use this 2014 as the start of a all-oral DAA genotype 1 regimen, we peaked within 1 year, and it's been going down ever since. And that's a real challenge for us, right? And that's why we're seeing these numbers of only 1 in 3 or 1 in 4, because of the challenges of really getting people recognized, diagnosed, and access to care. And again, what are the predictors of access to care? If you're a male, if you're in the baby boomer cohort, right? you're more likely to get treatment. If you are white, you're more likely to get treatment. Now, there's a lot of missingness about self-reported race and ethnicity in this database, so I think that's a limitation. And if you're on commercial healthcare, you're more likely to get treated. And we're going to go back to this, right? Why is there a difference between Medicaid and commercial? And we'll talk about that. And I do think we've made a lot of headway on that front. I think I showed you all this as well. I'm not going to belabor this point. It shows again that there are disparities in access to HCV treatment. But the other thing that I think is really important to think about is actually here, and this is about once you're diagnosed, what is the chances that you're going to get started on HCV therapy within 6 months? If you have Medicaid, it's, what is that? Somewhere around 17%. If you are on Medicare, it's somewhere around 22%. And if you have a commercial insurance, it's about 30. Within 6 months. I mean, this is why we're 1 in 3, right? Is that the majority of people getting diagnosed aren't getting started on therapy. And I would argue once someone's diagnosed, there should be no delay as far as I can tell, right? They should be getting treatment. Ideally, treatment in that same day, right? That's how we get over this hump, I think. And you can see that if you go to the next 6 months, that number doesn't go up much, right? So we're way less than 50% of people are getting treated for their hepatitis C, even within the first year of their diagnosis. And that's, we're not gonna overcome this major hurdle if those numbers continue. So part of this has been driven by restrictions from insurers. Medicaid has definitely been the one, probably the most under the microscope, and the National Viral Hepatitis Roundtable has done a huge service to all of us by really making this front and center and showing us these numbers over time. And I don't know how many of you have followed this, but it's pretty cool to see how this map has changed. This map is largely in the greens and yellows, but for those of you who remember 10 years ago, this map was largely in the oranges and reds. Almost every Medicaid state Medicaid had significant restrictions on access to DA therapies. And now you can see that 28 states no longer require prior authorization. That's huge. That just happened in North Carolina, and that's huge. No state any longer has fibrosis restrictions, which means you don't have to wait until you have cirrhosis to get access to treatment. That's huge. And I'll show you others, right? Prescriber limitations and even retreatment, which I know had been a struggle for many. 37 states no longer deny access because a patient is getting retreated. So this is a huge step, and I think many of you were advocates in your state to push against this, and it shows you that your voice, can change things here. And I think this will likely drive changes in those numbers of 1 in 3, because a lot of this change has really happened in the past couple of years. And what we're seeing in the past 10 years is a reflection of a state that was much more red and orange in terms of the grades of access. And I did circle Arkansas. Anyone here from Arkansas? Arkansas definitely, by far, is the state that continues to have the worst grade. I know that Iowa shows up there as well, but across the board, it's like, not good. So we may need to help Arkansas out here. And then I'm going to highlight, something regarding, access, right? And I don't know how many of you practice in a VA. I do, and it's interesting, right? I practice at Duke, and in a private insured, in a private health system, and then I practice at the VA. And I just have to walk across the street, and the difference in access is dramatic for patients in terms of HCV care. And this is a recently published paper in CID this year that really highlights how, when there is a commitment to doing this, it actually can be done. And it can be done in those groups of people that, we have identified as more difficult to get to engage, or in those groups that you saw with other insurers tend to be the ones where there are disparities in access. But this shows you that if you take those sorts of restrictions away that ultimately do not favor people from underrepresented groups in our communities, you actually can get over this barrier pretty quickly. So this is a summary of where the VA health system is right now. They believe that they have probably identified within this cohort about 93% of the veterans with known HCV or a history of HCV. You can see that this is a very diverse population, and I just summarized that population here. I think key demographics, almost 40% identify as Black or African American. 25% come from a rural area, almost 50% from the South or Southeast, where we know we see some of the greatest disparities in terms of access to HCV cure. And you can also see in terms of comorbidities that may be viewed as predictors of not being able to access care. Many of those younger groups that we're talking about right now is really struggling nationally to access care. 50% with alcohol use disorder, 22% with opioid use disorder. And not surprisingly in our VA healthcare system, almost 75% with an underlying mental health diagnosis, right? 80% of these veterans have been treated. And predictors of access to treatment, compare this to what I showed you earlier. Identifying as Black or African American, being from a rural, highly rural area, you're more likely to get access to treatment. Having an alcohol use disorder, more likely to have access to treatment. Having a mental health diagnosis, more likely to have access to treatment. Now, where we are struggling, I think consistent with across the board, is younger population, the population that's actively has an active drug use disorder, and unstable housing. And so those are some of the areas that we really need to fix. And I'm actually going to share the last slide of this presentation with you to show how in our VA we are trying to get to this based on data from Norway. And then, so 92% cure. So of those 80% of veterans, 92% of them been cured. What are predictors of cure in this VA population? This could be true of the entire United States if we did this right. Race, Black or African American, self-identified, mental health diagnosis, and HIV co-infection, right? Since when is that a predictor of having better access to care, higher access to cure? Remember, people with HIV historically were the ones who did not have as high of a cure for HCV, and that's now flipped, which is fantastic. So I think this is really a success story and shows that this can be done if we commit to this. So in terms of key populations, this is my last few slides, is really just to focus on that younger group, people that are actively injecting, people that have unstable housing, and other social drivers of health that we recognize as really limiting the ability to access care. That could be transportation, that could just be general difficulty with being able to get up in the morning and get into the clinic, things like that, right? Recognizing sometimes the difficulties in not having stability for any of those social drivers. And this is a really nice study done. It's called the HERO study that really looked at people who inject drugs and have injected in the past 90 days, which means that they are a pretty key population here in terms of increased incidence of HCV infection. This group tested several strategies to say, how can we better keep these folks engaged in care and get them through treatment? And they really tapped into what I would consider to be kind of more decentralized or less traditional research sites, right? Opioid treatment programs, community health centers, et cetera. And you can see here that, and I maybe say adherence was good, and the SVR rate was actually almost 90% in this population. So this can be done. And again, if you look at the modified intent to treat, it's lower in the 70% range. But if you look in the per protocol population, you're getting close to 90%. I will say, we can have this conversation too. Do we feel comfortable with that? Are we gonna have an expectation of these folks that we have to get to 98% or 95%? Are we comfortable that with this population who has a very high risk of onward transmission, that 70 or 80% for now is better than what it likely would be, which is these people not having access to treatment and having risk of onward transmission. So I talked about pill in hand. I think I talked about this study, and I'm going to move through it pretty quickly so I can get to the last two. But I do think that the concept of getting over the barrier of that continuity, the continuum of care, which is from diagnosis to being able to see a provider who's going to get them pill in hand, this study did this. They didn't have point of care testing, so they couldn't do a diagnosis, test, and treat in the same day, which is where we need to be in this country if we're going to overcome the barriers. But what they did do is they tested them, gave them a 7-day pack, and said, we're going to get your results and we're going to bring you back. And if you don't have hepatitis C, because they went by point of care antibody testing, if you don't have hepatitis C, then we're going to stop therapy. But if you do, we're going to keep you going. And what you can see in these light blue lines is those people who got that dose pack were much more likely to stay in care. Those patients who kind of got the standard thing, which is, we're going to test you and then we're going to have you come back and we're going to go through the results and we're going to talk about treatment, you lost them. And you lose them right here, which is that step between diagnosis and re-engagement in care. So I'm going to go through two studies in the last 4 minutes to just highlight where we could be, right? And how can we overcome some of these barriers? So one is pill in hand. One is gonna have to be point of care testing and being able to give people drug when they're right there in front of us in the clinic, right? And that clinic may be, again, a syringe exchange clinic or other, maybe in the emergency departments. I don't know how many of you were at Croy and saw this result, which is another ACTG study that's looking at people with acute hepatitis C. This is probably one of the last studies we'll see in acute hepatitis C. And what this really tested was, in a single arm, whether or not 4 weeks of the GP regimen would be sufficient in this population. You could say, why 4 weeks? The concept of 4 weeks is you can basically give someone a month's supply of drug, and if they can take that 4-week supply, because we know that the longer a course of therapy, the decrease in adherence, generally speaking. So if they can get 4 weeks in, what is the chance of cure in this very high-risk population of people who, if they're getting HCV infection, they're at risk of onward transmission, but it also probably means that there are some other risk behaviors that may decrease the ability for them to continue in care. I will tell you that the other reason that 4 weeks may be of interest, and it sounds like you all heard about this yesterday, is the concept of an injectable, right? So it may be harder to create an injectable for an 8 to 12-week course. It may be easier to create an injectable for a 4-week course. And so we need data to understand whether there is a regimen that could work for 4 weeks. And that's really what this looked at. It's the second study that's larger on the larger side of things that looked at 4 weeks. About 50% of these folks had HIV, 50% did not. A large part of those 50% who did not were on PrEP. And what you can see here is that the overall SVR rate was about 85%. That's the take home here, okay? In this slide, what you're seeing in red are the people who had relapse. There were 6 relapses, there were 2 reinfections. And largely, as we've seen many times in acute hep C studies, the higher your viral load, the less likely you're going to be able to have a shortened course of therapy be successful. We can talk about this as well, but I would say that an 85% SVR rate in this population is not bad. And I do think that this supports the concept of a 4-week long-acting injectable regimen. And the last study that I'm going to talk about here is one that really thinks about how do we get to these young people that we are missing, besides point of care, which I'll talk about in the last slide. But this is a really interesting study that was just published in November in CID. And it was a study that was done in Norway, and it was looking at getting access to people in the hospital. And you all are taking care of folks who are injecting. They come in, they have bacteremia, they have endocarditis. We've been talking about this for a long time. How do we get them access to treatment in the hospital? And they really looked at this. Can you get them access to treatment either in the hospital or on the way out of the hospital? And if you do that, versus the standard, which is you might make a diagnosis in the hospital, remind them they have Hep C in the hospital, but they have to follow up in the outpatient setting, can you increase access to treatment? And what this slide shows you is access to treatment. Yes, these are people who got treated either on the way out of the hospital or during the hospitalization. These are people who are standard of care. Now, what's interesting is if you went and followed these folks and you looked at their actual cure rates, the arms converged, and it was only about 60 to 65%. The difference in the lack of achieving a virologic success was it was lost to follow-up for the people who got access to treatment, and it was not getting treatment for the people who were in standard of care. I would argue one of those is better than the other. Because many of these folks were lost, it doesn't mean they weren't cured. It just means that the team didn't have a virologic outcome. So what I'll tell you is that we have started doing this in our VA hospital. We are now using national data that tells us when a patient walks in our doors, either for an ED visit, a hospitalization, admission to our psychiatric ward. It picks up national data. So many of the people that we've picked up, even in the past week, which were 5, were diagnosed at a different VA, and we did not know. And we are approaching them in the hospital, and we are trying to get them pill in hand before they walk out the door. There are ways that we can do this to really increase the access for these patient populations. All right, so I'm 1 minute I'm 14 seconds over. So the elimination plan, where are we with the elimination plan in the United States? So they have put out kind of more information on the focus and the target of this. And again, I think similar to last year, it's really targeting 3 primary areas. Diagnostics. So the word on the street is that we hope to have a point of care diagnostic approved by the FDA by the first quarter of 2025. That's huge. We just have to learn how to use it, and we have to do studies to really show how do you implement that in the real world, right? broad access to curative HCV therapies. We've just talked about this. Barriers are coming down. How is the US government going to truly get those barriers out of the way? And we talked, I think, last year about the concept of the Netflix plans and things like that, and we could talk more about that. And then the last piece really is implementation. It's gonna have to happen in a decentralized manner, and really the idea is focusing on these clinics where patients are approaching or are coming in for care, and really trying to get them at that point of care, and what we call a single visit program, right? We have to do this as part of a single visit program. That will be the future, I think, of HCV therapy. So I will stop there and thank everyone for listening.
Well, thank you, Susanna. That was a wonderful overview of kind of where we stand a decade into DAAs. And I would ask you to think back to Charlie Flexner's talk yesterday where he talked about long-acting GP, potentially how that would fit in if you could give a one shot into some of those scenarios that Susanna talked about. Really exciting, Charlie's talk yesterday. So I'm really thrilled and to ask Sham Kotalil, who is the chief of the Division of Infectious Diseases at University of Maryland, which you could literally throw a baseball and hit from where we're standing right now. It's just up the road. He's going to talk, he is a translational researcher who's done everything from the lab all the way to implementation sciences with some cutting edge treatment. And we've given him a really challenging talk, which is management considerations for hepatitis B virus. And if that wasn't enough, we asked him to talk about Delta or HDV as well. And I'm really thrilled that he's come down the road to share his thoughts and insights into these two important viral pathogens. Yeah.
Thank you, Mark, and for the committee for inviting me to give this talk. So these are my disclosures. The objective of the lecture is to understand management of chronic hepatitis B and chronic hepatitis D, and go in a little bit more about the life cycle of hepatitis B. Hepatitis B is not that common, and most of our practice in US, most of you may not be as familiar with the management of hepatitis B than hepatitis C, for example. So we'll go in a little bit more in the details and understanding how what we're doing well and what we are not doing okay. Hepatitis B, there are 240 to 300 million people live globally with chronic hepatitis B. In the United States, it's about 1.4 million people. It is mostly a migrant disease. Most people with hepatitis B have come from other countries where there is much more prevalence. So for example, in Asian Americans, there's 1 in 12 prevalence rate compared to other groups. It is the leading cause of hepatocellular carcinoma in the world, and hepatocellular carcinoma is a rising cause, and that's why we are concerned about hepatitis B. Most of the textbooks will say that hepatitis B is transmitted from adults, etc. But the current mode of transmission of hepatitis B is from the mother to child. That's a major form of transmission. The children can actually get from other children or being associated with adults in the postnatal period. So in the early childhood is when you're likely to get hepatitis B these days. And that's the main mode of transmission. Hepatitis B is an interesting virus. It's a DNA virus. It's the only hepatitis virus that's a DNA virus. Most of the other ones are RNA viruses. But it uses a reverse transcriptase enzyme to replicate, which makes it interesting. It's called a hepatna virus, and it is extremely tropic to liver. It doesn't really go anywhere else. It just go to the liver. So liver tropic research. Other than human beings, the only other host we have is chimpanzees. So Barack Bloomberg classified Australia antigen in the Dane particle. You can see that as part of the hepatitis B surface antigen that exists in 3 different forms, the large, medium, and small. And then you have a nucleocapsid that consists of the core protein and the other different components of the core nucleocapsid, as well as the enzyme, reverse transcriptase enzyme. The genome organization is very interesting because it is an incomplete genome. And because each part of the DNA can actually code for multiple different parts of the virus. So how transmission happens is that the long transcript happens, and from the long transcript, you chop down and make different pieces of DNA. This is of academic interest, but usually hepatitis B replicates in the liver in a very interesting way. So this clearly shows the diagram for replication of hepatitis B life cycle. It gets into the liver cell, it slowly makes its way into the nucleus. And when you get into the nucleus, it really becomes two things really happen. And that's actually highlighted here. One is become a CCC DNA, was covalently closed circular DNA. That is a circular form of DNA that is not integrated, but is associated with the nucleus. It can incorporate different host protein, histones, and become transcriptionally active and makes most of the components of the hepatitis B virion particle. At the same time, it also integrates into the DNA. So that's the part is shown here. You can see that this part is an integration happens. That is sometimes can be transcriptionally active. We'll touch base on that like 3 times during this presentation. So there will be a CCC DNA, and there is also an integration DNA that happens. So the life cycle as it continues, as the cccDNA is formed, cccDNA then undergoes transcription, forms what you call as a pregenomic RNA, and from the pregenomic RNA, different components and proteins are translated. Ultimately, all these things are put together in an immature form of a capsid that you can see here. And from there, reverse transcriptase will work and convert that single-stranded RNA to double-stranded RNA. Hepatitis B DNA, from virology point of view, it's called a pararetrovirus. Pararetroviruses are retroviruses. The DNA retrovirus uses reverse transcriptase. For us, there's only one clear good example is this. The difference here is that this particular stage, it is formed in immature capsid. It is not encapsulated completely. You need to have double-stranded DNA. The whole reverse transcription and the double second strand synthesis has to happen for the virion to get out. So that's usually blocked in that part. The second point is that you can see the site the cccDNA is formed here is earlier than what you see for the reverse transcriptors actually happening. The reverse transcriptors is where most of our drugs work. And I will touch base on later. So that means that all these agents have no effect on the formation of cccDNA, which is a big deal for curing hepatitis B like we do for hepatitis C. We can keep it suppressed like HIV, but when you stop, the cccDNA can become really active. Hepatitis B has like multiple phases, and usually, when you first acquire, I told you that you get it when you're very early childhood. We have an immature immune system. At this point in time, you become what you call as an immune-tolerant disease. That means you have a lot of hepatitis B in your body, but very little immune response. So if you do a liver biopsy of these people, you will see tons of surface antigen and core antigen. You can stain for it, but you have no ALT elevations or no inflammation in the liver. So that's called immune tolerant. Most of these people are very young. They are E antigen positive. They're very high DNA level. As you progress, some point they will actually break tolerance and started having ALT elevations, and they previously used to be called as immune active patients. These were the patients who were more responsive to interferon treatment. And then subsequently they will lose the E antigen status completely. And most of the patients who are about 45 or above with chronic hepatitis B will be E antigen negative, because this is the process of you growing up. The more you live with hepatitis B, you start manifesting one phase to another. Then you become an E antigen negative phase where the viral load is actually much lower. You may have elevated ALT levels, and you have a low replicative phase. If your viral load is lower, viral load is higher, become a high replicative phase. So this is what you see. Unfortunately, people can jump from one place to another, and that do happen in your clinical practice. So something that you keep an eye on what happens with these patients in terms of there. So to summarize, you start from the beginning. 90% of those people become chronically infected, and when they're chronically infected, they go into two different pathways. One, to develop progressive fibrosis, cirrhosis, hepatic liver failure, and death. The other process will be to have hepatocellular carcinoma occurring, and that also leading to complications associated and can lead to death as well. Most viruses like hepatitis C, alcoholic liver disease, NASH, most of these things follow a very common pathogenic pathway called necroinflammation. So they actually lead to a lot of inflammation in the liver, massive death of hepatocytes, and liver is a really rapidly regenerating organ, leads to rapid regeneration, and that cycle continues over time, becomes cirrhosis, and they develop hepatocellular carcinoma. That's the main cause of that. Hepatitis B is different. It can do the same necroinflammatory pathway, but in addition to that, it also integrates. Whenever there is a foreign DNA material get integrated in your genome, particularly in liver cells, they have rapid regenerative capacities. There is a risk of developing malignancy, liver cancer. So they actually have an increased risk. So there's an added risk of developing hepatocellular carcinoma, which makes it quite distinct from other types of hepatitis viruses that we discussed today. And this is shown that what can we do to prevent HCC, the REVEAL study has shown that if you have viral load, your risk of developing hepatocellular carcinoma is much higher. And the lower the viral load, your risk of viral replication and hepatocellular carcinoma is much lower. So that's something that is quite known. We can do something about it. We can reduce the viral load and reduce the risk of people getting hepatocellular carcinoma. I just want to tell you a couple of things that people don't really understand. If you ever had hepatitis B and completely resolved, and you have no antibodies, you have no antigen level, no DNA, your risk of developing hepatocellular carcinoma is not zero. It's not the same as the general population, because some degree of integration has already happened, and your risk is slightly higher than the general patient population. This is something people have to understand. We probably often do not really recognize in clinical practice. So that's one thing to remember. Your risk is going to be there. Then all these additional things like inflammation, like ALT levels, high DNA levels, and e-antigen status, all additionally contribute to your risk of developing hepatocellular carcinoma over the course of the time. So this, how does the risk of hepatocellular carcinoma with hepatitis B lie in terms of, it's a tough time for us to relate, particularly for, from our primary care perspective when you deal with these patients. Most of us as clinicians understand that smoking leads to cancer. That is quite understood. We taught in medical school, etc. So this is a very large study that we did with Homi Razavi from CDA Foundation, looking at analysis of about almost 1 million patients. And the first figure here shown is the adjusted hazard ratio of smoking 1 pack a day and the risk of developing cancer in that patient population. Not surprising. All of us will understand that this is something that is acceptable, and we understand that the risk of cancer associated with smoking. But what we don't recognize is the risk of developing hepatocellular carcinoma if you have surface antigen that is positive. And even there is the green diagram shows about hepatitis C, the small number of patients, but the same true. The risk of developing hepatocellular carcinoma when you have a patient who has surface antigen is very high. I don't work for the tobacco company. The message is not that tobacco risk is lower. The message is that the risk of hepatocellular carcinoma in surface antigen positive patients is higher, as high as somebody who's smoking 1 pack a day. And that's something we have to wear, so we need to screen. So why do I say this is before? Why do I say this before? Again, is because if you have hepatocellular carcinoma, your mortality is quite high. And about 50% of the people will die within the 1 year. And that's because not that we don't have really great agents to treat hepatocellular carcinoma. Often they're diagnosed late, they're multicentric, and leads to complications in management. So what can we do? We can actually stop the prevention by putting the patient on treatment. We'll talk about that data later. So that's one thing we can do, put them on antiviral, and also can screen using ultrasound in our patient populations to make sure that they do not have hepatocellular carcinoma. That's something that we really have to do. So moving on to, I talked to you about that there is integration to happen when hepatitis B is going into the life cycle. Some degree of integration happens with the DNA. And whether this particular DNA is transcriptionally active is something which is debated for a very long time. We got an answer for this specifically by looking at this particular study done by Christine Woodall. She used to work for a company called Arrowhead, a commercial company. They made one of the first siRNAs against S antigen. So this siRNA will prevent S antigen formation from cccDNA. It's exclusively designed to block cccDNA transcription, and they used it in chimpanzees to see if this actually works. The goal was to reduce surface antigen and levels and whether that can actually lead to functional cure. So when you gave to the chimpanzees who were e antigen positive, you can see there was a very nice decline of surface antigen reduction that expected, but did not see any decline when you have e antigen negative. So what is the difference between e antigen positive and e antigen negative? So what the data tells you that most of the S antigen in e antigen positive chimpanzees, and probably in humans, is made from cccDNA. But in e antigen negative patient, it is actually coming from the DNA that is not coming from cccDNA. Where is it coming from? It is coming from integrated DNA. So it makes sense because as you go older, you lose e antigen, and every time hepatitis B replicates within the liver cells, it integrates a little bit. So when you live longer with hepatitis B, the chances that you have more and more integration that happens than you are much younger. So in the younger, so that's what usually happens when you're e-antigen negative. Now you have a problem that most of your S antigen is coming from a different source. This is the integrated DNA, not cccDNA. This is important, especially when we're concerned about developing a cure for hepatitis B. And how does it really know that? So you can actually now measure all the DNA material. We can also look at the other measures like pgRNA. There is an ultrasensitive surface antigen level. A lot of these tests are commercially available. Do we really have any role in using these tests in our clinical practice? One of these tests is like in pgRNA that's shown here in the orange bar, and the core-related antigen. Core-related antigen is the quantification of the core and the e antigen. You can quantify these core and e antigen levels. And the reason why you quantify is because these are actually made by cccDNA. So you want to know whether cccDNA is transcriptionally active even when patients are actually taking reverse transcriptase inhibitor. So that's one way of quantifying. What exactly is the role? So this is a Kosh Agarwal study that was published a couple of years ago. This clearly showed what he did was he took patients and treated them with tenofovir for 5 years and then stopped. So when you see here, you can see that the blue diagram is DNA. When you start treatment, the blue graph is completely gone to 0. That means DNA is completely undetectable. You have really good virological control of these patients. However, you can see that the orange and the green graphs persist. That means cccDNA is still active. They're still making different components of hepatitis B, even though the virions are actually not formed, and because the reverse transcription level is actually blocked. And again, after 5 years, a significant number of patients actually have detectable pgRNA and core-related antigen levels actually persist. So why am I telling you all those things? What is the role of these things? So this is good to know, but when then he stopped treatment. So we worry about stopping treatment for hepatitis B because you can actually have relapse, and some of these relapse can be really bad, and it can lead into fulminant hepatic failure. So when they stopped the treatment, some people had really bad flares, and many people did not have flares. The dotted graphs is not really good. The dotted graphs are actually the one with the really, really bad flares. You really want to know who these people are so you can follow them better. And this is not advised in clinical practice to stop hepatitis B treatment. It's not related to your previous DNA levels. It is not related to S antigen level. But if you look here, the pgRNA level, the people who had higher levels of pgRNA and high level of correlated antigen are the people who had really bad relapse. So the only advantage of this new test is that if you decide, if you really want to stop treatment for someone in your practice, you've taken medication for such a long time, you may want to check these things, make sure these are also less undetectable. If they're high, they're very likely they're going to have bad relapse as well. So there are a variety of biomarkers available to monitor hepatitis B. I will come back and summarize this in a bit. The prediction value of these biomarkers of disease progression are validated in small cohorts, but still needs to be validated. The only use that I said is because if you really want to stop treatment, you want to use this may be helpful for you. Many people do not stop treatment unless they are in a part of really structured monitoring system. And the other one is that if you are really incorporating functional cure, you're really targeting cccDNA, then these markers will become very important, but that's not really part of clinical practice a lot. So evolution of treatment, the first time, when Brosh Blomberg discovered Australia antigen, we had a preventive vaccine developed very quickly that was very effective. But then the first medication was reverse transcriptave medication was lamivudine, which is already being used for HIV, was repurposed for hepatitis B. Since then, we had adofovir and telbivudine, multiple, tenofovir, TAF, and entecavir. So right now, most of the medications we use are tenofovir, TAF, and entecavir. Because of the emergence of resistance with other agents, and interferon is also being used. The interferon, many people in parts where hepatitis B is prevalent, interferon is very commonly used, not particularly in this country. A lot of people use different low-dose interferon for a long time, variety of different things for tackling hepatitis B, which is not endorsed by guidelines, but still something that people use. But we don't really use that much in this particular country, interferon at all. But most people get tenofovir, entecavir, or TAF. The treatment algorithm is quite confusing, and as Susanna mentioned about the hepatitis C, how we evolved over time, and you heard yesterday how we evolved with HIV treatment, treat some, treat don't, treat some, every now and then. Hepatitis B is complicated. So it's basically based on two different parameters. If the basically viral load and ALT. You need to have elevation of ALT and you need to have viral load elevation. Viral load elevation for e antigen positive person is going to be quite high, so it is, the limit is about 20,000 or more, and you have to, then those people have to be treated. And if you're e antigen negative, the same thing applies. The only group of people treating is that HPV DNA level is more than 2,000 and you have abnormal ALT. So this is always contentious. You know, like as an infectious disease doctor, I always worry about that. Why do we not treat people who already have tons of virus in the body, right? There's always tons of debate. But the guidelines are always based on what is level of strong information that we actually have. The data is the strongest, that these are the group of people who can show really good effect of treating patients, of reducing fibrosis progression as well as clinical outcomes. I think the field is moving forward. I think in the next year or two, many of these guidelines will actually start expanding the number of patients to be treated. And a lot more patients will be treated eventually because they do have a lot of virus. Maybe other risk of transmission, et cetera, may also be considered in treating these people. So good news is that once you treat them, they do very well. So most patients will hepatitis B DNA will come down, and all these different agents have done the same thing, and ALT is normalized, and that's exactly what you want to prevent fibrosis production. If you know ALT is normal, then you really don't have fibrosis progression over time. So this can be really accomplished. And you can also reduce cirrhosis. There are studies, this is a study using tenofovir. 75% of the people who had biopsy-proven cirrhosis when they started tenofovir were no longer cirrhotic 5 years later. So that's the reversal of cirrhosis of fibrosis. That has been shown in every single agent, lamivudine and other agents as well as tenofovir. So you can normalize ALT, and if you consistently take it, you can actually reduce the progression of liver disease with hepatitis B. And that's really, really, really not. So what is not clear? What is that you still have no S antigen, you still have S antigen in your body. That S antigen is not affected by antiretroviral treatment. Even after any of these medications, the S antigen loss is very dismal. It's a very small number of patients. That means when you stop treatment, cccDNA is active, and you can hepatitis B DNA, you will be back to where you are, like you have with HIV infections. So it is not, it's like curable disease. So that's something that has to be concerned about that. I told you that mother-to-child transmission is great. So why don't we do anything about mother-to-child transmission? There is definitely data suggests that you can actually treat the mother and prevent mother-to-child transmission. Most hepatologists, most infectious disease doctors who deal with hepatitis B, if you encounter a pregnant woman with hepatitis B, would put them on antivirals. But we don't really see pregnant hepatitis B in this country a lot, right? So we don't, but that is pretty common. The problem is that people getting to the specialist to get to that care. Most of the time they don't get there. They will not know that hepatitis B, and then only after they have the deliveries happen. The best study is CalPEN study. CalPEN did the study treating patients and pregnant women on the 3rd trimester who had DNA levels more than 200,000. And it was shown that per protocol, nobody, if you treat them in 3rd trimester, none of the infants were transmitted with hepatitis B. That's great. And so large studies need to be done, and this is part of the, but still people generally treat the patient for a longer time. The hepatitis B, there's debate whether the transmission may happen a little bit earlier also, even though this study did not show that difference. So I told you there are a variety of different markers. What all markers we do in clinical practice? Very little. HPV DNA we have to do because that's what we are targeting. So we need to make sure the HPV DNA is suppressed. That's something that most more routinely done. There is a quantitative surface antigen. There is an ultra-sensitive antigen. All these things are actually of only of academic benefit. It doesn't really apply to clinical practice. Unless you really want to stop treatment, you're reassured that the quantified surface antigen is quite low. That's helpful, but usually there is no particular level of surface antigen that helps us guarantee that this person is going to have relapse or not. And I already talked about E antigen. There is a quantified E antigen. There is no consistency there. Not many people use them, so it's not recommended to do that, even if it's available. Then you have correlated antigens available, and those antigens have very limited application along with pgRNA. So most of these tests are available now, commercially available, in anticipation of some of the functional cure studies that are coming through. But in the current stage, other than the DNA and ALT, many of these markers are actually have very limited role in routine management. So where we are is that we would like to have something like Dr. Nagy mentioned, right? Like for hepatitis C, hepatitis B, you should have a functional cure, a sustained virological response. So it means you stop, there should not be any DNA, and there should not have any surface antigen as well. And our current treatment is not going to get you there. So there is always question what else we need to do. So I'm not going to go into details, but there is an active area of research in this space. What generally believe that there is a cccDNA is a reservoir for hepatitis B, and as long as that is active, it's going to produce subunits, and that subunits is going to suppress your immune response against hepatitis B and maintain hepatitis B replication in the body. Until you address that particular issue, and the current treatment is not addressing any of these components, unless we address that, we cannot accomplish cure. So there are strategies we're using to block cccDNA transcriptional activity and also boost immune response in parallel that's happening. And hopefully in the next few years, we will have a better idea about it. There are immunological deficits do exist in chronic hepatitis B patients specific to HPV. And targeting cccDNA or innately alone does not seem to really get you the numbers that we achieved with hepatitis C. So those numbers are really not achievable with the current approach. Some point in the future, we will have to combine these approaches to get to where we are with hepatitis C. I want to switch gear in the next few minutes and talk about hepatitis delta. Hepatitis delta, if you think hepatitis B is interesting virus, hepatitis delta is even more interesting virus. It is what is an incomplete virus. It doesn't even exist as a cold virion. What it does is it hijacks hepatitis B and then use hepatitis B to replicate by itself. And it's a very, very small virion, one of the most smallest virions that's available. It actually has its own delta antigen, but it also has maintains some of the hepatitis B antigens, like hepatitis B surface antigens as well. So how does it do it? So you have in the left side, you have hepatitis B, where you have the nucleocapsid along with the reverse transcriptase, and you have all the S antigen, the different forms of S antigen surface displayed on the surface. The hepatitis D antigen, what it does is that this is an RNA virus. So it actually gets into the cell by binding to the S antigen. Once it gets into the cell, it will hijack the entire machinery, and now you have an RNA nucleocapsid of the hepatitis delta, and then it also, in addition to the surface antigen, it starts having its own delta antigen called HD antigen as well. So now it becomes hepatitis delta on top of hepatitis B infection. Hepatitis delta, the epidemiology is not very clear. This is from the CDC, and this is not very accurate because there is two types of people. People either test for delta or don't test for delta. So there is no information available, and we rely on international data or where people come from, etc. for delta. Really don't have a lot of understanding about the prevalence of hepatitis delta infection here or in other countries. There are definitely pockets of infection with very high. Turkey, in Mongolia, and parts of Pakistan, Karachi, that they have reported very high incidences. But they are small tertiary center studies. We don't really know whether that's applicable to the entire Turkish population or Mongolian population. We really don't know about that. Those things need to be done in the future to be able to do that. So there are about three things to remember, hepatitis C. So if you have a co-infection of delta and hepatitis B, you always spontaneously resolve both. So that's not how you get delta, right? Because then you resolve. So how you get delta is that you have chronic hepatitis B, and on top of that, you have another exposure, either by substance use or sharing a needle or other contact, you get delta infection. And then at that point in time, it is almost 100%, you get a chronic infection of delta. So you have chronic hepatitis B, you get delta on top, you get chronic hepatitis delta. Now, it's usually, most people, I told you that most people may not, there is a some people test for delta, some people don't. And the reason to test for delta is that you have a chronic hepatitis B doing well, you have an elevation of ALT, unexplained, and then you suspect you have something else, and that could be delta infection. Why does it matter? Is because delta infection causes the most aggressive form of viral hepatitis. So you have very rapid progression on aggressive form of hepatitis. So that's something that is there, and there's really not very good way to treat delta as well. So what do we do to prevent? You prevent Hep B, you prevent delta. So if you don't have Hep B, you don't have delta. So universal vaccination for hepatitis B is something that we advocate, and that's been picked up in most countries. That's great. Treatment is with interferon with very limited response up until now. So the reason we are having this discussion is because of some interesting developments that happen, and there may be some new therapeutics may be coming out that may have a role. Before that, let me just go through a life cycle a little bit. So actually, delta gets into the cell, binds to the surface antigen, and once you actually get into the nuclear capsid, it forms this delta antigen, transcribes the RNA transcribed into the delta antigen, the large HT delta antigen. This delta antigen undergoes a process called prenylation. Prenylation, for people on biochemistry understand, is a lipid post-translational modification of a farnesyl group into this. And why is that important? That particular thing is important for the delta to form assembly of the delta virion, and then the delta virion can actually be excreted into the blood circulation. So that is a critical step. If you can block that prenylation step, that assembly does not happen. And so a drug called, Jeff Glenn developed this drug called lonafarnib, and that drug can actually block this particular region of prenylation, and that has an effect on blocking HDV replication. People may know about lonafarnib. Lonafarnib is approved for a condition called progeria, using the same principle. The prenylation of the cascade of the protein, progeria protein, is affected, and it can actually, progeria is an accelerated aging disorder. Anybody trained at NIH would know. You see that cohort of patients who are coming there. Little kids become aged very rapidly, and they will die before they are like age 20, in their teens, they usually die. So this particular drug is approved for that, and the same principle. In hepatitis delta, we use the same thing because it affects prenylation of that. The other agents are entry inhibition. There is an entry inhibition that Stefan Urban developed, it binds to NTCP, and they block the entry of surface antigen. Both surface antigen compete with surface antigen and delta antigen in getting into the cells. They also have effect on delta. This is called a bulevirtide that's been used in clinical trials. And then the third agent is a replicor agent of nucleic acid polymer that is of some unknown effect. What it does is that it somehow interferes with assembly and release of the virions. Also seems to have effect in blocking agents and hepatitis D delta replication. So how does this work? This is the data on lonafarnib, phase 2 study that Shihan did. Lonafarnib has to be combined with ritonavir to get boosted drug, which is one problem. And then if you get the maximum effect, like the 4-log drop of effect that you need to get in delta viral load, you need to add interferon as well. So these are the two complications. You have to add interferon weekly injection and take ritonavir. And if you do that, you can have reduction in delta level. It just doesn't leave you cure. When there is a reduction in delta RNA, you have normalization of ALT. Those are the things we expect, so there will be less progression of liver disease, and that's the goal. The goal is quite different here. Bulevirtide has been, again, studied in phase 3. Bulevirtide combination, they use like a combined response, either to have a 2-log drop or less than quantified level of delta virus and normalization of ALT. About 50% of the people had it 1 year. These are injectable, daily injection, so how the uptake of these medications will be in general public once they get delta diagnosis is not sure. So that's something to be seen, but at least there are availabilities here that the delta RNA comes down with 2 milligram and 10 milligram dosing. That comes down quite nicely 1 year. You can actually have ALT improvement also, about for half of the people will have improvement in normalization of ALT. So these two things is available. And that's the way the delta is moving. And I summarized that multiple strategies have been developed to treat delta infection. These strategies will have shown declines in HDV RNA levels. I'm not quite sure whether they lead to functional cure. At the moment, there is no data to support that there is a functional cure, and people will have to be on this medication for a long time. Some strategies require additional immune-based therapeutics like interferon alpha, and that may also complicate things. And the lack of effect on hepatitis B is a little bit concerning, that whether they really lead to functional effect or not, because hepatitis B is there, it's difficult to get rid of delta. Thank you.
Well, fantastic. I warned you folks it was a complicated topic, and Sham really walked us through those 2 viral pathogens that are obviously integrally related in a fabulous way that we'll have a chance to talk about clinically. So I do want to take a minute to remind folks at home that you do have the ability to ask questions. Go ahead and type those in, and they'll come to me here on the podium, and I can pose them to our panelists. I do recognize it's early out there. Maybe some additional coffee and some questions. So I'll start with some questions that came up. You all touched on hepatocellular carcinoma, and maybe you could just, Senna, you didn't touch on this, but cirrhotic patients with Hep C, Cham told us they needed to be screened. When do you stop screening a cured cirrhotic?
Now that's a great question, and there are studies that have tried to look at whether or not you can follow largely non-invasive markers to better risk stratify people over time. The overall story on post-SVR, if someone comes into HCV treatment, this even goes back to the interferon era, with severe liver disease. And I always like to say severe liver disease because none of our diagnostics for cirrhosis are specific enough to truly tell you for certain whether or not someone has cirrhosis versus really severe fibrosis. And so I tend to lump people together into that kind of pathologic F3, F4 status. But if they're coming in with severe liver disease, the data that we know over the long term is that their risk for HCC will continue for at least 10 years. It's kind of the number I usually give to the patients I meet with. And there are a number of groups, including in the VA, who have tried to look at FIB4, for example, a non-invasive marker. Folks have now started to look at transient elastography to see whether or not over time they can actually identify a marker post-cure that would be able to risk stratify people to know whether or not they're going to go on to develop an HCC. I think the data is promising, but I am not yet comfortable. I don't feel like we yet have the data to say that we have the level of accuracy with a non-invasive test after a cure to be able to look someone in the eye and say, I can tell you that you no longer have a high enough risk of liver cancer that I can remove you from a surveillance screening program. So to date, I continue to screen all patients who come in with severe liver fibrosis for HCCs every 6 months. Right now, I say it's for life. What I tell them is my hope is that at some point the research will help us understand when you can stop this, and I think it's coming, but I don't think we have it yet. That's my response.
Well, great. Let's go to a microphone.
Yes, our very beautiful presentations. Question for both of us. First question of Dr. Nagy is the SVR, when you finish treatment for hepatitis C, you're supposed to do SVR after 3 months. You do it, when did you stand that? Like, for example, as an ID, if the patient doesn't have HIV, I'm not going to follow them up. Yeah. So what suggestions? I finished my treatment. When do I recommend, okay, do it in 6 months, in a year, have them come back? In which circumstances, or what kind of, causes determine your decision? Now, for hepatitis C and B and screening, you always do ultrasound on patients with hepatitis B, chronic hepatitis B. Even if they don't have cirrhosis, you always stop stream. And then the other thing, that treatment plan that you have on your VA for patients who have diagnosis of hepatitis C is very interesting. How do you get the money for that? Because in my, in my institution, they barely have money for anything. So it's a very interesting project. How do you get the funds to do that?
Yeah, right. So I'm happy. So I'll start really quickly with the SVR question. So if I understood exactly the question, so SVR 12 is what we say is cure. And I try to get folks pretty close to that period. We know that is over 99%, right? So maybe 1 in 1,000 people will have viremia that is not reinfection after that SVR 12 visit. So the way that I tend to do it is if I can get people back, I try to get them back sometime around SVR 12. Anytime after that is good. And if I send them, if they don't have severe liver disease and I say you're cured, I usually return them to their primary provider and I ask them to repeat 1 year later to be sure that they are not one of the 1 in 1,000. I don't know how many of you, but we have literally had our 1 in 1,000 veteran who relapsed between SVR 12 and SVR and 1 year. And so I do that. I mean, again, is it necessary in a program nationally to get to elimination? No, but in my clinic where I have resources, I do it, if that answers your question. And then,
yeah, take that. So you're absolutely right that the hepatitis, if you have chronic Hep B, the Hep B can lead to non-cirrhotic HCC. So the recommendation is that regardless of your fibrosis stage, you really screen them with ultrasound. So that's one of it. Sometimes it is very challenging because many of our patients don't have insurance, they're not documented, and to getting ultrasound is $200. It's actually quite challenging. We find that in Baltimore, many of our cohorts the same problem. I just also want to make one comment on Mark's question, which is very important. I think there are two types of Hep C treatment, right? One is the experts who actually have engaged in care, like in the VA system, where you have adequate follow-up. And then we are advocating for everybody, anybody to treat and take pills. That's where these things could fall apart, right? When you are in established care, you actually have all these other follow-ups of complications of Hep C is well set up. But when you do large-scale treatment, we don't emphasize so much about all these other cares looking for HCC, because as Dr. Nagy said, there is a risk for HCC well into after the treatment. Those are the things we really need to pay attention when we scale up our Hep C treatment.
And regarding the resources for getting people who are coming into the hospital, I mean, I'll say this, right? We're talking about trying to do this at Duke and the VA. At the VA, we have had a long-standing, very positive relationship with the pharmacy team at our VA. From the very beginning, you know, when they really wanted us to use what I would consider to be a regimen that we may not have been as excited about. It was more complicated, maybe had more side effects. But we agreed, like, we're going to try to do what's most fiscally responsible. And we worked very closely with them to develop the kind of the best approaches that would save the VA the most money, but still get people access to treatment. I think that resulted in a relationship where now that we want to do something that's a little bit different and honestly a little bit outside of their comfort zone, they're more willing to work with us on that. I do think that nationally, out of a socialized VA healthcare system, the potential for this is real. We're going to try to do this at Duke as well. Now that prior authorization is off the table, right? So I think if we can get to a point of no prior authorization, then the big challenge becomes the in-hospital formulary, which they're never going to carry a Hep C drug, and trying to work with our outpatient pharmacy, which is exactly how we're doing at the VA. They won't let us order it inpatient. So what we do is we order it outpatient, and then we take the drug to the patient in the inpatient setting. Yeah.
So to add to that, the VA, more than 20 years ago, in the interferon era, pulled together a national plan for hepatitis C. And they pulled together their VISNs and set up pathologists and the whole 9 yards. So this has been a long time. They were ready for DAAs, unlike the rest of us. And certainly part of the goals of the national plan will be to copy some of what they've done. It will just take an act of Congress because it's in the budget for which I'll leave that one alone. But so, there is the potential to replicate that. So let's go to the microphone.
Okay, so in the past, years ago, we used to think that once somebody had resolved hepatitis B infection, they were done. And then we had some liver transplant patients. A couple patients were reported who had reactivation of previously resolved hepatitis B. And then we ran into this conundrum of people on Rituxan who were reactivating. And recently I saw a patient who was on anti-metabolic chemotherapy that got referred to me, and I said, oh, you don't have to worry. And then when I looked the drugs up, they are also listed as may cause reactivation. And of course, there's a ton of rheumatologic disorders and treatments. And so I have really a conundrum about how often to screen, because a lot of these patients I would consider still low risk if they're on an anti-metabolic drug, but then I'm supposed to screen them. And how often am I supposed to screen them?
Yeah, it's a very, very good question. I think the literature is quite scarce in making clear recommendations on this. But one thing is that the biggest risk for are people who are isolated core, right? These are the people who actually core antibody, but you don't have surface antibody or surface antigen. So if you have surface antigen, most people will be on treatment. So then if you have surface antibody with high level, then they actually have resolved infection. But this has become the occult HPV group. It could be, not everybody will be in that group, but there'll be some people will be occult, kind of like people who are suppressing their hepatitis B by using their immune response. And in something you do with the immune response, they can just trigger back up. Very difficult to diagnose it unless you do liver biopsy with the nested PCR and everything, which is not routinely done unless in research setting. So that's where the challenge comes up. If somebody like that comes to getting a therapeutic that would suppress the immune system, then the recommendation becomes, and it comes to ID doctors to be able to make that decision. Some of them are clear-cut, like Rituxan is the most associated with the response. Even though antibodies does not seem to have a major role in controlling HPV, Rituxan somehow has a way of overcoming HPV immune response, maybe FC mediated or not, some response there, which is not clear. The rest of the medications are much rarer. But so this is the group I would think. If you're isolated core, they're going to immunosuppressive treatment, then it's likely to either monitor them very closely, or in things like Rituxan, they will actually go in on an HPV treatment until they are on immunosuppression.
And I might add just really quickly to your point, I think that historically the AGA had guidelines that made recommendations about how you risk stratify. I always like to teach our fellows that it's about the patient and their serology, which you can list as high risk, surface antigen positive, to the lowest risk, positive surface antibody but a positive core, and then the drug, right? And then but the AGA tend to move away and very clearly had language that they did not have enough data to recommend a monitoring strategy. I would just highlight to folks that a meta-analysis came out that's led, I think Nora Turow is the senior author on that, but we can get this to the group, that provides, in my opinion, the most updated recommendations on how to risk stratify. And they do endorse a monitoring strategy for people who fall into those lower risk groups like you were talking about. So I believe that's the most consistent with my current clinical practice. And to me, it's the most updated recommendation that we have regarding how to manage these kind of different risk assessments based on drug and patient.
So I think
I'm sorry. The difficulty is that it's a rare occurrence, right? Not everybody will do that. Not everybody with isolated core will actually have that. But when it happens, you have a chance of getting fulminant hepatitis B, right? So that's where we are cautious, and if we are encountered with that, we will definitely monitor them very closely and start treatment with low threshold for starting treatment because we anticipate a bad outcome. There's never going to be enough data, randomized clinical study to look at that kind of scenario.
Yeah. So you raised. Yeah, go ahead.
I was going to say, in the literature that I've read, it says not to, in some of the guidelines, it says you can take in the presence of surface antibody. But in some of them, it says just ignore surface antibody altogether.
Yeah, that's a really important point. It's unclear that the surface antibody positivity lowers the risk, and in part because we just don't have good data. But so the way to think about it is anyone who's core positive, the assumption is they have the potential for reactivation. But you really raised an important point. They are coming up with new monoclonal antibodies against the human immune system, it seems like every month. So, and they're being used by different practitioners, dermatologists, rheumatologists, you name it, they're being used across the board, and the guidelines aren't keeping up with risk assessment. So I think it puts us all in a challenging situation, the evidence-free zone in many of these areas. And I want to emphasize the point made, some people who have reactivation because it's missed can flare and have fulminant hepatitis B, and there have been deaths reported with flares. So my bias is to use antiviral prophylaxis when in doubt. So I tend to lean towards that way and give people something relatively benign. But it's a really important point, and one the guidelines can't keep up with. It's, these days.
Mark, I mean, the one thing I would say is I do think there's really good data. And a lot of this comes out of Taiwan and other countries where the rates of prior exposure to a positive core is very common. That actually shows that a monitoring strategy is safe. So the truth is, the people who have fulminant hepatitis are the ones where someone isn't paying attention. And by the time their liver enzymes are elevated, they're in trouble, right? It's really hard to put that Hep B horse back in the barn. But if you are aware that there's a risk and you're monitoring them with a DNA and liver enzymes every 4 weeks, it is highly unlikely, if you identify an increase and you put them on drug, that they will go on to fulminant hepatitis. That, I feel, we do have very good data about.
Yeah, except, well, I'm gonna move on because we've got some questions online, but no one comes back every 4 weeks for the DNA test, and that's the problem. But I want to get a couple online, and then we'll go to the microphone. So for both of you, what about the criminal justice engaged population? We have a question coming asking about, well, what about prisons and jails and Hep C and Hep B? What are we doing there?
Yeah, I mean, I think, so again, let's use, for example, Louisiana as a state example, right? Louisiana decided that they were going to go in on the Netflix model, and the populations that they were going to focus on was the justice-involved population, the Medicaid population, and they were able to show a significant decrease in HCV-infected persons in their state. I will tell you that the U.S. elimination plan very specifically, just like Louisiana, identifies the justice-involved population as a key population to treat, to eliminate hepatitis C in this country. So I think everyone gets that this is a population that is highly relevant and critically needs access to treatment.
Yeah,
For Hep C.
I would just make one comment about Hep C treatment. Like, if you're treating the vulnerable population, which is the main reservoir of hepatitis C globally and particularly in the United States, these people are going to go into prison at some point. And that we're going to have to engage the prison system to continue this treatment. Otherwise, everything is just going to be not that useful in eliminating. So engaging the prison population is critical. Hepatitis B therapeutics in area is like the prevalence and the very, very little hepatitis B therapeutics screening is done in the prison systems, at least that I'm aware of. And that's just one of those really difficult challenges that we have in convincing people. And most of the times when they have a fixed amount of dollar, how many things you screen and how many things you treat, all those things will come into issue. But it's really very suboptimal.
One thing they could do is just vaccinate people. Right.
Well,
that's what they should do.
Yeah, it's a big topic, but it's really important to recognize that in the U.S. it's heterogeneous across states, federal, and then jails, and to have a policy regarding screening that is actually paid for and endorsed is challenging. So it's a great question, and we appreciate that one from the audience. We'll go to the microphone in person and then try to get back online.
Hello. So I have a question about hepatitis B. Is there any data about the transmissibility of very low levels of viremia? I have a patient who was a healthcare worker and sort of right at the borderline, and I may have decided not to treat if she was not in that position, but I didn't, I don't feel comfortable signing that form that says they're free of communicable disease. So if there's any information about how you would manage that.
It's a great question. We're smiling because we've been talking about the idea of treatment as prevention in this population beyond mother to child. And you raise a really important topic, which is healthcare workers with hepatitis B, where I'll just summarize what this sort of SHEA says. They say they actually pick a viral load threshold and they apply it to, they say it's okay if you're on treatment, and they apply it to people in high risk complications, think cardiothoracic surgery in terms of things like that. So but it's a complicated area. There's not great guidance. So maybe I'll ask both of you, what are you doing with healthcare workers or others when they ask you about treatment and transmissibility?
Yeah, I agree. I think there is not clear like an HIV where U equals U with hepatitis B. So we have to use a lot of our clinical discussion part of it in the healthcare system because hepatitis B is so much higher transmissibility with blood products. So depend on the type of exposure. We have very low threshold of prophylaxing or post-exposure prophylaxis and started treatment of healthcare workers in that time. The set points, as Mark mentioned, it's just very arbitrary. It's not very data driven, and at some point we're just going to have to use when you provide guidelines, and you're going to have to use that. So I think for us, for that perspective, we have very low threshold for especially the type of patients we see are the E antigen negative, low viral load people, right? That's the type of we don't really encounter the early high viral load younger population as a partisan most of the time, so it becomes tricky.
But certainly a reasonable reason. If someone is concerned about transmission, it's a reasonable thing to treat, although it's not guidelines driven.
Yeah, she's been on medication for a couple of years and is now asking if there's a possibility to come off, and we're discussing like how would we monitor that, and is this the right time? So thanks for
that's a whole nother can of worms there. You just opened up with stopping therapy, and we'll touch on that actually in one of the cases. So. I do want to ask a real simple what I hope will be a quick question before we end our panel, which is laboratory reporting of viral load results. So, Susanna, for Hep C, sometimes it comes back and says less than, let's say, 15, and sometimes it comes back and not detected. And I know I like to see the words not detected. It makes me feel good. But do you consider the less than 15, are they cured as well?
They sure are.
Okay.
That's my short answer.
Now, so... Good. It's just lab reporting. It's how they. So the same thing with Hep B. Sometimes they come back. You got someone on treatment. You're giving them long term, let's say tenofovir, and sometimes it comes back. They're not detected. You feel good, warm and fuzzies all around. No MyChart messages. But then sometimes they come back less than 20 detected. MyChart messages come in. What should I do? Should we? What do you tell them?
Yeah, I think we run with this problem within the early Hep C days when we have all these Abbott testing and and Roche PCR testing. So quantification is where the FDA really pays attention to. That means you really want to make sure that's quantifiable. When they say less than quantifiable, that should be the data driven. And other times when you do PCR, you can get a signal, but it's not quantifiable. So that's when they have to report it based on the regulations of the NCCLS. These things, because they're clinical testing, they report them. And we are then challenged with what to do with this thing. It doesn't feel good that it's detected, but it's not quantifiable. So I think most of us will just go with the quantifiable, even though less than detectable makes us feel better.
Yeah, so reassurance of those. But so I want to thank our panelists. I will say to the person online who asked about co-infection, I deferred that because I think you're going to get your answer to that question in the next session. So I want to thank Susanna and Shyam for really excellent presentations. And I will say that the questions about hepatitis B are really just, they're fantastic, and it's really a very complicated area, both with treatment as well as even the diagnostics. And we didn't get to some of the questions that I think are critical. And co-infection is even more complicated because now you've taken a complicated virus like hepatitis B, and where Shyam told us the immune system is important in control, and now you've added another virus with immunodeficiency, shared risk for acquisition, so high prevalence of co-infection, and really increase the complexity of this patient population. So really thrilled to welcome back Deepika Bhattacharya from UCLA, where she's professor of medicine. She also leads the ACTG Hepatitis Transformative Sciences Group, which is laser focused on hepatitis B cure, particularly among people with HIV. So I'm thrilled to welcome her back and up to the stage to take us through the management considerations for this important population of people.
It's always the first question of the afternoon or morning. Can you see me? Yeah, okay, I'm gonna stand to the side a little bit. Thank you very much. Thank you, Mark, for having me back. Very delighted to be back this year. And I should say, thank you for that very kind introduction, but I'm filling very large shoes. Dr. Salkowski and Dr. Nagy, both of them were former chairs of the hepatitis TSG. So very, very good company. So I'm very excited to talk to you today about management considerations for hepatitis B co-infection in persons living with HIV. And I think, so these are my disclosures. So here are my objectives. So we're going to be talking about HBV vaccination and some considerations in persons living with HIV. We've talked a little bit already about the isolated anti-core serology status, and so we'll talk about that. We'll also talk about some really exciting HBV vaccine clinical trials data led by Dr. Sherman and colleagues. And then I want to talk about probably the single most prevalent question that I get, which is management with switch to nucleotide-sparing regimens in those with core antibody positivity. And then I want to talk about just general management of hepatitis B co-infection in persons living with HIV, particularly with TAF, tenofovir alafenamide versus TDF. I want to drive home a couple of points about incomplete HBV virologic suppression and then some unintended consequences of treatment cessation. So with that, we also have a couple of audience response questions here. So do we have... do folks have a way to answer questions, or are we going to do it by hands? Yeah, okay, we do have them, okay. All right, so Dr. Kodalil already covered a lot of this, but I think it's just always important to start with the why. You know, why should we care so much about the global burden of hepatitis B disease? And in fact, when you think about it, 257 million people globally have hepatitis B. And when you think about those with HIV, almost 8% of persons living with HIV also have hepatitis B co-infection. So that's almost 3 million people globally with HIV and hepatitis B co-infection. And as Dr. Kodalil kind of nicely already laid out for us, hepatocellular carcinoma, or HCC, is the third most common cause of cancer mortality globally. And when you look at HBV, that represents about 40% of liver cancers. So there's your why. It is such a large burden of disease. And in fact, when you look at surface antigen prevalence in the United States, we know that certain populations are at higher risk for those. And so foreign-born, those who are foreign-born are at greater risk of having hepatitis B surface antigen prevalence. And when you look at the general population, you can see the Western Pacific region is the most represented there, and that's also the most represented in terms of our foreign-born populations, in terms of being infected with hepatitis B. So we've discussed the why. Why is Hep B so important? Well, let's talk about the other why, which is the impact of HIV on hepatitis B disease progression. Can you still hear me okay if I move here to the side? Yeah, okay. So when we talk about the impact of HIV on hepatitis B disease progression, it's actually profound. We have higher levels of hepatitis B viremia, right, in those living with HIV. We have higher mortality when compared to those with HIV or hepatitis B. Dr. Chloe Teo at Hopkins demonstrated that really nicely in a large cohort study using the MAX cohort, which demonstrated a 14 times higher mortality in persons living with HIV and hepatitis B compared to HIV or hepatitis B alone. There's a higher rate of chronicity, so if you're unfortunate enough to be exposed to hepatitis B, you have a higher rate of developing chronic hepatitis B. But despite all of that, those with HIV actually have lower ALT levels. So what we measure for assessment of liver disease can lead us in the wrong direction, in the sense that ALT levels might be spuriously low in relationship to the degree of fibrosis that's present. There's a faster progression to cirrhosis, and less relevant now because we don't use lamivudine anymore as monotherapy, but there's a higher incidence of lamivudine resistance. So clearly an impact of HIV. And so again, Dr. Kodalil, I think, very nicely went over this great graphic about the hepatitis B life cycle. And so I won't belabor it, but I do want to make a couple of really important points. One, there are two deficits to hepatitis B in terms of establishing chronic infection. And the first, I'm going to try this now with the marker here, I said I wouldn't, but I will, is this integration here of, or rather the establishment of what we call cccDNA. This is the latent reservoir of hepatitis B, and this is why hepatitis B can reactivate. So that's kind of point number one. And as long as that is there, you're always going to have the risk of reactivation, and we do not have therapies now that can kind of edit that out. So that's very important. The second point is that in addition to that cccDNA, that reservoir, there's another tiny reservoir that's integrated DNA, and that's integrated into the host genome just like HIV. The other important point I want to make is that just like there is a viral reservoir, that's one barrier to cure, but there is another barrier to cure, and that's really a defective immune response. And that's largely driven, we think, by CD8 responses, but also by B-cell responses and innate immunity. The last thing I want to leave you with, and this is going to make you a superstar like on when you're being asked questions by your patients or colleagues, and that is why, if you have people on therapy for hepatitis B, with the HBV viral load being suppressed, why are you still making surface antigen, right? That was a common question that we were getting asked. And it turns out that there are two parallel pathways for production of hepatitis B. This is another reason this is such a wily virus. So one pathway just produces the proteins, and that's what you see there. And those are the surface antigen subviral particles and also other protein markers. And that is why you have the surface antigen production. In addition, you have another pathway which leads to the mature virus and the virions that are produced. And what happens is, with nucleotide therapy, you stop this pathway. You do not stop this pathway. And so you are going to have, as long as you have cccDNA, you still have the potential to make surface antigen. And the reason that we're able to bring surface antigen levels down is largely because of, obviously, of course, decreasing the viral replication, but probably also largely because of the immune response. And some people's immune responses, even in the setting of therapy, are going to be different. So, so 2 pathways. I think that's important to remember. Okay, now, let's see. Do we just say, how do we get rid of this? Trash can? I was worried. I thought I was going to trash can everything. All right. So, so then when we talk then about the interpretation of HBV serologic findings, I think this is always kind of helpful to remember. It's kind of a walk back to medical school. I'm sorry, but always useful to remember. So remember, we're looking at 3 tests: the surface antigen, the antibody to the core, and then the antibody to the hepatitis B surface antigen, right? So surface antigen, core antibody, and surface antibody. So if all 3 are negative, that person needs to be offered vaccination because they are at risk of developing hepatitis B. If you have somebody who's surface antigen negative, but core and surface antibody positive, those individuals are immune due to previous hepatitis B infection. But remember, they still have cccDNA, right? They still have the core that's positive. So they will also still be at risk for reactivation, although perhaps less so than another serology that I'll tell you about. If you are surface antigen negative, core negative, and surface antibody positive, wonderful. That person is immune because they received vaccination. You did a great job. If somebody is surface antigen positive, core positive, but surface antibody negative, those individuals have chronic hepatitis B infection and they need to be further assessed for treatment. And if somebody is surface antigen negative, total core positive, but surface antibody negative, this is the famous isolated core scenario, right? And what this scenario means, so remember now, you've got core, so that's like your quick and dirty for cccDNA. So you have exposure, but the surface antibody is negative. And in this setting, it can represent a number of things. Resolved infection is the most common, but also less likely these days with tests, but false positive anti-core. You can have low-level chronic infection or occult HBV that we've been talking about because of surface antigen mutations, or resolving acute infection. But the most likely is this resolved infection. And the reality is that most people with this serology, if you were to test them every 6 months, over a period of time, they're going to flip. They're going to flip their serologies from surface antibody positive to surface antibody negative. And the surface antibody being negative is likely a reflection of their current immune status, right? So if your surface antibody is absent, those individuals likely have a little bit of a less robust immune response, and as you could imagine, are likely a little bit more likely to reactivate in the event of immunosuppression. Okay, so let's go to our first case. So this is isolated core and a medication switch. So this is a 41-year-old gentleman with HIV who is on bictegravir, tenofovir alafenamide, and FTC, is surface antigen negative, anti-core positive, anti-HBS. So what is that? What's that serologic profile? You can say it. Okay, yes, isolated core. Okay, and so this person wants to switch to cabotegravir rilpivirine. Their CD4 is 525. Their HIV is undetectable. Their HCV is negative. There is no concern for HIV resistance. Normal ALT, AST, a good GFR. So how would you counsel him? Now, I asked for 80s music, so, let's see how we do. for the music in the background. So, so what would you like to do? So continue current antiretroviral therapy regimen, switch off of HPV active antiretroviral therapy is absolutely contraindicated. Discontinue HPV active ART but initiate entecavir. Vaccinate for hepatitis B and start entecavir, that's a hepatitis B medication. Or vaccinate for hepatitis B and monitor for ALT elevation and HPV reactivation. And it's okay to go on to the long-acting injectable. Which would you prefer? All right, I don't have a lot to teach you all. So the majority got D, which was the correct answer. Vaccinate for hepatitis B and monitor for ALT elevation and HPV reactivation. Although I will say the continue current antiretroviral therapy regimen, because switching off of HPV active antiretroviral therapy is not necessarily a wrong choice. And I just think we do not have enough data yet to help inform that decision. But I don't think that's a wrong choice. But my answer was vaccinate for Hep B and monitor for ALT elevation. And so what I'd like to do here is first take you through why we need to vaccinate the isolated core. I'm going to review some new HPV vaccine data. And then I'd also, and then we can talk about reactivation. So the first issue here is the fact that this person with the isolated core antibody serologic status needs to be vaccinated for hepatitis B. So just because they have that evidence, the quick and dirty evidence of cccDNA with the core positivity, does not mean that they are also not at risk for hepatitis B. And so this was kind of a famous study now, almost 2 decades old, that demonstrated that in these individuals with isolated core antibody positivity, when you gave them a single injection of hepatitis B vaccine to look for antibody titers afterwards, which is how we measure kind of whether or not they need additional doses, that 21% of these individuals did not mount any response, so between or minimal response, 1 to 9. So this is an important group that needs to be vaccinated for hepatitis B, because remember, they also are going to be having, they may be having continuing risk behaviors that put them at risk for hepatitis B. And so in fact, when we look at the recommendations for isolated core antibody positivity and how we vaccinate, these are based on data that was done by French colleagues that gave 1 standard dose of hepatitis B vaccine to these individuals with isolated core, measured the surface antibody 1 to 2 months afterwards, and if the titer was greater than 100 milli-IUs per ml, no further vaccination is necessary because those individuals did demonstrate that anamnestic response. But if, however, that titer is greater than 100, then you would want to complete or less than 100 rather, you would want to complete that series followed by anti-HBs testing. Now, I will tell you that that is one approach. My approach is slightly different, and that's largely because I worry that folks are not going to come in, it's additional visits, and so I just do the full series in those individuals who are core antibody positive. But both approaches are present in the guidelines. Okay, so now let's talk about hepatitis B vaccines. We've got a lot of kind of exciting data that have come out recently. And so, one thing I want to mention is that hepatitis B vaccine efficacy in individuals with HIV it varies, right? And so if you look here on this slide, you can see anywhere from 50 to 80% in terms of primary series. Now, I will say some of these studies were done in older eras of antiretroviral therapy where individuals had lower CD4 counts, but in general, overall lower response rates. And so there was a landmark study that was done recently, published in CID, led by Dr. Sherman and colleagues, and again through the ACTG, where we looked at a newer hepatitis B vaccine, an adjuvanted hepatitis B vaccine called Heplisav-B, and it used a schedule of 2 doses of the Heplisav-B. So the benefit to Heplisav-B is that you can do 2 doses instead of 3, and you can do it at 0 and 1 month, right? That's Heplisav-B. As opposed to the standard other regimens, which are 3 doses, 0, 1, and 6 months. So this was Heplisav-B, and what they looked at were the 0 and 1 month, and because they also had to fulfill FDA requirements, they also did another dose at 24 weeks. And this was just in persons living with HIV. And what this study demonstrated, the Beehive study, demonstrated is that even after, when you looked at, even after that 2-dose regimen, when you looked at week 8 and week 12, which is when they measured the antibodies to hepatitis B surface antibody, to surface antigen, or hepatitis B surface antibodies, you can see that week 12, you already had a response, a seroprotection response of 94% in vaccine-naive persons living with HIV, which was higher than the other studies, which reported only rates as high as about 80%. And then if you gave them a 3rd dose and you went out to 4 weeks after that 3rd dose, that seroprotective effect was 100%. And I think most importantly, or very interestingly, I should say, what we're seeing here is that the proportion of individuals with surface antibody titers of greater than 1,000 were almost 84%. That is really high. And that has implications for the duration of the response. This study, which was done by the ACTG, is informing guidelines. And currently, we now recommend that persons living with HIV who are vaccine naive can get 2 doses, and this kind of confirms that, of Heplisav. And I think the big question is whether or not we should also be recommending 3. Sorry, that's taking us through those. And then the other really exciting trial that was reported as a late breaker at CROI just a week ago is the second part of this study design. Again, the ACTG Beehive study 5379. And what it did, so the first study looked at vaccine-naive individuals. This study looks at the vaccine non-responder individuals, right? These are the most difficult folks to vaccinate. And this study used the same approach. So individuals were randomized to either 2 doses of Heplisav, 3 doses of Heplisav, 0, 1 month, and then 6 months. And then the standard Engerix, or the recombinant vaccine, at the standard 0, 1, and 6 months. And this is what was reported at CROI. The primary results, dun dun dun, late breaker, is that when you look at the 3-dose vaccine series of Heplisav, again, 99% seroprotective response, 99%. When you look at the 2-dose, 93%, compared to the standard of care, which was 81%. And that difference there ranged from between 13 to 18% between these 2 doses. Now, what I'm not showing you here is the similar data about the proportion of individuals with very high titers, but that was also replicated in this part of the study. And so again, the current recommendations are to consider 2 doses of Heplisav for vaccine non-responders, but that's now going to probably move up because we now have more data, randomized trial data. But again, I think the question is 2 versus 3. You know, we know that this may have implications for duration, so that'll be an interesting question. Very exciting data that was presented. Okay, so now let's take a step back and let's go back to the isolated core antibody situation, right? So that person that we were talking about has isolated core. They're about to switch to a Cabril regimen. What do you do? Is this something that we can do? And so this was a large study that was presented as an oral at ID Week using the VA data. So this was the Veterans Age and Cohort study. And they identified almost 6,000 veterans with core antibodies. So this wasn't just isolated core, this was core antibody positivity. And they were defined as at risk. And meaning at risk meant that their medications were going to be, for hepatitis B were discontinued for whatever reason. And of those almost 6,000 veterans, they then followed them after switch and found that there were 39 cases with either new surface antigen positivity or HBV DNA positivity after being either undetectable or surface antigen or undetectable HBV viremia. And what's really interesting, and so that's about 0.7% or 1%, so not that high of a number of reactivations. And what was really interesting in this study that I still can't wrap my head around is the extended time to reactivation. It was almost 300 days from the time of switch to reactivation, which is a little bit of a head scratcher, to be honest. So this is the data that, just saying that there's a 1% risk of reactivation is where I have landed in terms of how I feel comfortable about being able to switch those with core antibody positivity off of hepatitis B containing antiretroviral therapy so they can go on, for example, a long-acting injectable. But I do have an approach. So this is not yet in guidelines. And so this is the Devika Bhattacharya approach. So, please keep that in mind. But I think that one should have a plan for addressing individuals who are going to be coming off of therapy. And so what I would recommend is that you review laboratory results before you're going to be doing the switch. Make sure that surface antigen, core, and anti-HBs are tested within the last 6 months. If anti-HBs is negative, vaccinate for Hep B. If surface antigen is positive, ensure no cessation of hepatitis B therapy. If they're isolated anti-core, consider getting an HBV DNA prior to the switch, and then LFT monitoring Q6 months. And then if they're also, if they're core positive and anti-HBs positive, consider just the LFT monitoring Q6 months. Okay, so here's case 3. This is our new diagnosis of hepatitis B. This is a 63-year-old woman with newly diagnosed HIV. Important points here are mild renal insufficiency, surface antigen positive, E antigen positive, and HBV DNA of 9 million. And now what would you do here? What ARV regimen would you choose? Would you choose A, dolutegravir, emtricitabine, tenofovir disoproxil fumarate? Would you choose B, bictegravir, emtricitabine, tenofovir alafenamide? C, cabril, or D, dolutegravir, abacavir, lamivudine? All right, okay, well, you all got the right answer, and that is we would do a tenofovir alafenamide containing regimen. But the interesting thing here that I want to raise is, if the slide advances for me, is that, it's advancing on my iPad here, but it's not advancing here. Oh, yeah. What I want to emphasize here is the Alliance study. So this was a study that looked at the comparison between TDF and TAF-based therapy, essentially. So this was a study that looked at individuals with HIV and Hep B co-infection and randomized them to either a TAF-containing regimen or a TDF-containing regimen. And what you saw in this study is that when you looked at early HBV DNA undetectability, you can see here that with TAF, there was a greater proportion of participants with lower HBV DNA. And importantly, there was a greater incidence of surface antigen loss, about 13% in the TAF-related arms versus TDF. Now, we have seen in many cohorts accelerated hepatitis B functional cure in persons with HIV, which we think is probably related to immune reconstitution. But I think this is very intriguing data. And the question is TAF better than TDF? I think we don't know the answer to that yet. This study has not changed guidelines. I think when you looked at the week 48 data, there was actually no difference in HBV DNA suppression, but I think this is still an open question. And then what I want to leave you with are a couple of notes about HBV DNA. So one thing that's important to remember is that incomplete HBV DNA suppression is common. So this was an observational study that looked at a cohort study of 133 participants or patients with HIV and hepatitis B. They were started on TDF-based ART, and when you looked at just 1 year on therapy, 54% still had incomplete HBV DNA suppression. So I think the important point there is to just make sure that you are monitoring for HBV viral loads and surface antigen and other serologies. And importantly, when you look at HBV virologic failure, HBV virologic failure, meaning detectable HBV viremia, is associated with complications. This was a landmark study that was done with the NA Accord data by Nina Kim and colleagues, and what they demonstrated is that even if you had undetectable HIV viremia, right, so compliance is there, adherence is there, but detectable HBV viremia, you were still at an increased risk of hepatocellular carcinoma compared to if you just had HIV undetectable and HBV viral load undetectable. So this is a problem, and this, to me, suggests that we should be thinking about other therapies that can drive down this with novel therapies, drive down HBV viremia. And so after a year on therapy, the patient is excited for a potential injectable HIV regimen. Maybe in the interest of time, we won't do the ARS, but the answer here is between she can discontinue HBV antiviral therapy, initiate long-acting injectable therapy, but needs to continue HBV antiviral therapy, or discontinue HBV antiviral therapy. You don't have to worry about anything, but maybe monitor for HBV viral loads and transaminases. The answer here is that she needs to continue HBV antiviral therapy. And there have been a lot of studies that have looked in the Hep B monoinfection world about cessation of therapy. And while that is being studied in the context of clinical trials, I think it's important that we should not be doing that without being in a clinical trial. And the number, what I want to point you to is the last study, which was a study that looked at over 4 years what happened after discontinuation of therapy. 61% of individuals had ALT flares, and hepatic decompensation happened in 1% of them. So here's my summary. The adjuvanted hepatitis B vaccine shows promise. There is some interesting data between TAF versus TDF with higher rates of surface antigen loss and e antigen loss, but it's too soon to tell whether this is superior. Incomplete HBV DNA suppression is common, so please monitor your patients with HIV and hepatitis B. HBV active ART cessation is not recommended in HIV and hepatitis B co-infection. It may be at one time, it may be at one point in the future in the context of a clinical trial setting and with newer drugs, but only in that context. And as Dr. Kotalil mentioned already, novel therapeutics for Hep B are on the horizon. So with that, I'll say thank you.
Great. Well, thank you for that wonderful presentation. You really touched on and reinforced some really important issues. And Debica gets her own panel. This is awesome. We get to ask her questions to answer. And we do have a lot of questions came in online. I don't see anyone here in the room at the microphone. I'm sure that will change, but let me go ahead and take some online questions. A couple of questions about vaccination. You raised the issue of the guidelines, the OI guidelines for HIV, people who are isolated cores, and the guidelines for HIV say vaccinate. What do they say for mono-infection, people without HIV?
Yeah, that's a great question, and I encourage those also on the expert panel to also speak up. You know, there is not a lot of great data, and I think, so currently there aren't any recommendations for vaccinating isolated core in persons without HIV, but what I would say is that if you are concerned about ongoing risk in a particular patient, for hepatitis B acquisition, I would vaccinate, because what's the harm?
Thank you. That's appreciate. And so it's a place where guidelines don't really say much at all to help us. So another question that came up, and it touches on co-infection, but it's actually the prevention of HIV with PrEP. And of course, there's a couple ways to do that. You can use a tenofovir-containing PrEP orally, or you could use a long-acting injectable PrEP, which yesterday we learned and we know is more effective. How do you handle the issue of HBV risk of acquisition? And relatedly, how would you handle an individual with Hep B who wants to take PrEP?
Yeah, those are all great questions, and reminds me that maybe next time we should have an HBV and PrEP discussion in the slides. So I think with regards to let's tackle kind of the most common right now, which is TDF or TAF-based PrEP, right? And so the guidelines are that you must screen for hepatitis B, right? Because TDF and TAF treats for hepatitis B. Before initiating PrEP, and we screen now, as you all know, actually April of 23, there were the recent guidance of recommending universal hepatitis B testing, right? So I think that's the first teaching point is universal hepatitis B testing is now recommended for everybody, but specifically for those who are undergoing PrEP, of course, that needs to be a part of it. Surface antigen, core, and surface antibody. If somebody has hepatitis B, surface antigen positivity, and you're about to initiate them on PrEP, that in and of itself is not a contraindication to initiate PrEP, not a contraindication. What you have to figure out is what their disease status is from hepatitis B and whether they need continuous therapy beyond PrEP. That's your number one question. And fortunately or unfortunately, the Hep B guidance is there are lots of guidelines, lots of different thresholds for when to treat. But I think the most important thing to remember is, do they or do they not have cirrhosis? Because if they have cirrhosis, there's no question. Those individuals need to continue on therapy, they need to continue on therapy lifelong, right? So those individuals need to be prioritized for continuation of TDF or TAF-based PrEP. I think the simple answer is, once you've done the screening and you've demonstrated that they don't have cirrhosis, then I would, and you're going to initiate them on PrEP, you can, TDF or TAF-based PrEP, but I would just make sure that you're doing it with somebody who has some expertise in hepatitis B management to help guide you. There have been studies that have looked at the setting where in TDF or TAF-based PrEP, you've stopped the TDF-containing regimen. Now, the studies that have looked at this have enrolled individuals who were at low risk. So those individuals had low ALT when they came into the trial. And when in the one study that looked at this, that looked at TDF discontinuation at the end of the study in those individuals with hepatitis B, almost all of them flared. They had HBV viremia, but they did not have clinically significant flares. Nevertheless, those individuals need to be monitored very carefully. And I also think the guidelines are in flux a little bit, and we may be recommending longer durations or more kind of consistent therapy with TDF or TAF-based therapy. That's TDF-TAF. If you go to Cabril, I mean, I think that the issue there is that you need to make sure that you are doing your serologies. If they are non-immune, that they have been vaccinated for hepatitis B. That's actually very, very important. And a rationale to pick one of the newer vaccines like Heplisav, because it's only 0 and 1 month, so it's quicker. And then to monitor them, we don't have guidance, but I would say based on risk factors, I would probably test them every 6 months for hepatitis B. Long answer, sorry.
Well, it's a complicated question. I'm just going to push you a little bit. So you've got let's say someone comes in, they're S antigen positive, E antigen negative, ALT is pretty normal, the F0 on your non-invasive testing, no scarring. Viral load comes in at 1,900, not quite at that 2,000 threshold for treatment, plus their ALT is normal. So you've got no indication for Hep B treatment for a mono-infected person with Hep B, at least according to current US guidelines. would you feel, how would you handle that? Would you use a TAF or tenofovir disoproxil fumarate, tenofovir-based oral, or would you go CAB to not treat?
Oh, that's interesting. I see where you're going now, Mark, with that question. Yeah.
I've heard people propose, because they're not supposed to be Hep B treated at that low level, according to guidelines, not to use something else.
Yeah.
I'm just curious what your thoughts are.
I mean, I think I would go with what the patient had the preference for. Do you know? I mean, so if the patient really wanted to be on a long-acting injectable, I don't see a contraindication to doing Cabril in that setting, right? To letting the patient get the long-acting injectable. My own bias is that, and I'll put my hand up and say, I think everybody with hepatitis B should be treated, and so I would probably counsel this patient that if they have hepatitis B and they are going on PrEP, if they come on a TDF or TAF-based regimen, we can take care of two situations with one approach, but that is not supported by the current guidance document. So I think either would be fine. My preference would be to start them on TDF or TAF.
It falls into sort of an argument that we should be treating more people with Hep B. It's, with Hep C and HIV, C virus, treat virus, Hep B, it's C virus, measure it multiple times, think about it some more, measure again. And in this case, it may be a reason to treat because you may also prevent HIV transmission. And there are data showing that the vaccination rates in Americans above a certain age are really low in terms of seroprotection. So anyway, we'll leave that one. And we'll go to the microphone. We'll start on my left, so this side.
So I have a question on co-infected, the persistent viremia for Hep B, someone who is on a TAF-based regimen. At what point would you consider the Hep B viremia persistent? And would you optimize with entecavir on top of your HIV treatment?
I know, that's a great question. So, I think certainly, so part of determining whether or not somebody has incomplete HBV virologic suppression is also looking at what HBV viral load they start out with, right? So if they started out with 50,000 and you get to a year and they're still unsuppressed, I'm a little bit more concerned than if somebody started out with 9 million and you're at a year and you're unsuppressed. But in general, if you get out to 18 months and you are still unsuppressed despite, appropriate therapy, that is a reason to kind of call it HBV viremia, incomplete HBV virologic suppression. What we think is the primary driver behind incomplete HBV virologic suppression, and Dr. Nagy and colleagues have kind of demonstrated this nicely, is that it's probably non-adherence, and it's probably short-term non-adherence. So folks, and for whatever reason, HBV is not as forgiving with regards to adherence than HIV is. So you can take your meds, potentially miss a dose a week maybe, and that's enough to suppress HIV, but not enough to continue to suppress hepatitis B. And so the first thing I would do is really kind of talk about adherence, additional adherence strategies, and really drive home that point about the increased risk of HCC. And after that, I mean, one could consider intensification regimens, and they have demonstrated in like 30% of participants to be able to drive down the HBV DNA even more. But I think that it's probably more about adherence, and I think that what this really indicates is that we need better therapies for persons with HIV and Hep B to really drive down with some of these agents like what we call capsid assembly modulators, which we know are probably even more potent.
Or another argument for Charlie Flexner's long-acting treatments with things like tenofovir, where you don't have to worry about that daily dosing.
Yeah, exactly. Yeah.
So we'll do some great questions. We'll do another in-person question. Go ahead, it's my right.
I'm Jose Chavez. I practice in Washington, D.C. I'm one of the ones that answered A in your first case. And I think it's important in your HIV patient that present with isolated core, what they call isolated core, that you look at the hepatitis B serology at the moment they were diagnosed before they start antiretrovirals. Because if it's a patient that has hepatitis B surface that you put on antiretrovirals a lot, it's a patient that will never be, someone that will never switch to a regimen that doesn't have hepatitis B core coverage.
I think that's a really important, tell me your name again.
Jose Chavez.
Dr. Chavez? Yeah, thank you, Dr. Chavez. I think that's a really important point. What I didn't mention is that in that ID Week poster that was presented from the VA cohort, the single most important predictor of subsequent reactivation was prior surface antigen positivity. And so, I mean, I think that's a fair point that, you know, if you have the records and you're able to go back and see that their surface antigen status and they were positive, maybe those are individuals that you don't, you know, prioritize for, or that you don't switch to a non-HPV active regimen. But I still think, and I just think we need more data, to be honest, but I still think the risk, the relative risk of the small kind of HBV viremia blips at this point doesn't completely rule out the option of just monitoring. So switching, but monitoring very closely. But I acknowledge that that's, you know, my personal approach and that we still need more data to inform that. But I think that's a very good point. The prior surface antigen positivity might be a reason to not consider that.
So I'm going to do one of the online questions because it pulls us back into this PrEP. Because although you answered a lot about PrEP, you didn't talk about 211.
Oh. Yeah.
And quite an astute question came in that said, okay, what about 211, which we heard yesterday, you know, is, you know, 2 doses of TDF containing PrEP and then 111. So what about that in someone known to have Hep B?
No guidance, but I wouldn't do it. I just would. I mean, I worry about kind of the, I'm not actually worried about incomplete or suboptimal medication levels. I'm just worried about continuous potential flares, you know, with starting and stopping.
Well,
but I'd be curious. Yeah.
Yeah, it's a great question. I will say there's not resistance to tenofovir for Hep B is rarely reported, but 211 sounds like a good way to really, you know, underexpose the virus to
test the
tenofovir levels. So we'll go back into so I think in general, a person with active Hep B defined as S antigen positivity would not be a candidate for 211. All right, we'll go to the microphone. We'll start on my right over to here.
Yes, we keep hearing a lot about PrEP, but we haven't said anything about the sexual transmission of hepatitis B, and especially those who have low-level viremia. And we know in HIV the cutoff in the study was at 200, but what about Hep B with less than 2,000? And you're talking about not treat, and we talk about sexual transmission of hepatitis B, but what about also IV transmission of hepatitis B?
You're preaching to the choir here. I completely agree that that is an issue, although you know, again, the data is a little bit more sparse with hepatitis B than it was for HCV and HIV. And I'm not aware that we have a viral load criteria for sexual transmission. We have a viral load criteria for perinatal transmission, and that's 200,000 IUs per ml, but we don't have a similar cutoff. But I think that that is also of concern, sure.
It's an area, I think, of the unmet need for research because it really hasn't been tested. There's the cutoff. So for pregnant persons, it's 200,000. The SHEA for healthcare workers picked that it should be below, I think it's 1,000 or 1,500, something in that range. And then I looked for the references of where they got that, and it was unreferenced, so apparently, so I just think we don't have a lot of information, but it does come up in the PrEP context. So it's an interesting area that research has not really fulfilled, in part because it's complicated by vaccine. So it would be unethical not to vaccinate the people you're trying to study at risk, but how do you tease that out? And it's a pretty tough question to answer.
Yeah, no, absolutely. But, you know, in regards to a potential patient counseling question, though, I mean, we always say, and I think that's important to point out, is that when you have somebody with hepatitis B who's coming into your clinic, in addition to assessing them, you need to assess their household. So, you know, who are they living with, who are they intimate with, making sure that those individuals are tested and vaccinated is also important. And so for somebody who has hepatitis B, even with low-level viremia, of course we want to vaccinate their partner But I think there's an ongoing discussion there to be had about other strategies to prevent transmission.
We'll do one more question in the room, and then we've got a few online, back to core antibody positivity. But
Hi, how are you? Dr. Guerra for Lauderdale. Yeah, I have one comment and one question. Yes, I do try to agree in treating more hepatitis B infections, especially if we have family history and history of cancers, which is very important to decide upon treatment, have patients which decide to go for treatment for those reasons. But my question is when to stop hepatitis B treatment in non-co-infective, of course. I mean, because it's difficult, and there's the resolution of hepatitis B survey something I haven't even seen it, or very few cases.
Yeah.
To hear your thoughts.
Yeah, it's a great question, and again, welcome my colleagues to also address it. But I think first it's important to say who you should not ever stop therapy in, right? And so one category of persons are those living with cirrhosis. So those individuals, we should not stop therapy once starting, because if you stop and they flare, that could be that could lead to death or liver transplant. The next category of persons that are unlikely to come off of therapy are those individuals who are in that e antigen negative but active disease phase that you've decided meet criteria for threshold. Those individuals are usually older. We call them e antigen negative disease. They're usually older. We have a lower threshold for treatment initiation, a viral load of 2,000 versus a viral load of 20,000. And overall, their risk of long-term complications is higher. So those individuals are likely going to be on lifelong therapy, the e antigen negative who you've started on therapy, the e antigen negative with chronic Hep B. Then the last category are those who you started potentially when they were e antigen positive because they had active disease, and then over time they have potentially lost e antigen and or had HBV viral load suppression for greater than a year. And there are some guidelines panels that suggest that you may be able to take those individuals off of therapy. Again, I personally don't feel comfortable with that approach because I think that there is enough data that demonstrates that HBV viremia itself is probably instigating adverse effects. We're learning a lot about DNA integration effects and how that may influence the risk of HCC. My practice is that I generally don't take patients off of therapy, but you might. There are certainly some guidelines that in those e antigen positive patients who have achieved HBV viral load suppression for a year or more and have demonstrated e antigen loss, you might take them off. The final category that I think there's just a lot less data on are the ones who are fortunate enough who go on to, after treatment, who lose their surface antigen and who then become surface antigen negative plus or minus surface antibody. And I think again, it's mixed. I think there are some people who do feel comfortable, stopping at that point, and there are others that don't. I would probably favor continuing for some time, but I'd be happy to hear what my colleagues do.
Well, I do want to get to, I'll just say that when people lose surface antigen in my practice, mono-infected, I will treat for a year and then stop. Consolidation therapy, but so far so good. It's worked out pretty well. But not many patients actually have that happen.
Yeah.
So it's an uncommon event. I want to try to do some just rapid fire core antibody positive questions. So we'll limit Debica to sort of yes, no answers. No, because we're coming up on the break here, and I think it's, I'm going to try just a few in. Okay, core antibody positive, PrEP. Any concerns about choosing a CAV PrEP regimen in someone who's Hep B core antibody positive?
No data, I'd monitor.
Okay, so that was a yes, they can take. Okay, perfect. Let's see. Answered that one. Okay, isolated core antibody positive. Do they need hepatocellular carcinoma screening? We've heard about this evil virus and how it integrates into the human genome. Core antibody positive patients we think are past infection. Is their cancer risk increased? Do they need screening?
No data at this point, no, unless they have other risk factors for HCC.
Okay. And then a person who's going to start immunomodulatory therapy, the question we had earlier, who's monoaffected, core antibody positive, antibody negative, S antibody negative. So you said in HIV you would vaccinate, but now they're coming in because someone wants to give them rituximab. Would you vaccinate that person?
No data, probably.
Okay. And this is the
You
last.
said rapid fire.
I said rapid fire, yeah. Yeah, the argument there is there's no harm in vaccinating that person, and you could certainly do that. What is your approach now for someone, you touched on this with the Beehive study, a very important study about vaccine non-responders. Someone comes in, they were vaccinated, let's say it's a healthcare worker, got vaccinated when they took their first job, now they're S antibody negative. You talked about monoaffected patients, but what's your approach in general to that person, let's say a healthcare worker who's now S antibody negative, potentially looking at HBIG, et cetera, if they were to get a needle stick? How would you approach them? Would you revaccinate? And if so, what would you take the Beehive regimen?
Yeah, I would revaccinate, and I would do Beehive, and I'd probably do Beehive. I would do Heplisav, and I'd probably do 3 doses.
Okay. Well, thank you. I feel like we really worked, Debica, very hard during this Q&A session with some really difficult questions. With my colleagues, Steve did not help me here. So we really appreciate you covered a lot of territory, a really fabulous answer discussion. So we are due for a break, and then we'll gather back around here at 10:45, and Dr. Sherman will walk us through metabolic-associated cytokine liver disease. So go enjoy some snacks at break and come back and talk about fatty liver. So we're going to leave viral hepatitis behind, although as the questions both in the room and online indicate, you can really not talk enough about hepatitis B. It's a complicated virus and a lot of questions. But we're going to shift to what I would describe as a growing problem, both in the US, where we have a rising concern about what's been called in the past fatty liver disease. And for those of you who are at CROI or have looked at updates from CROI, you'll know that fatty liver disease, or what's now termed metabolic dysfunction associated steatotic liver disease, is an important problem for people living with HIV. We touched on that a little bit yesterday with weight gain and antiretroviral therapy, but Dr. Ken Sherman, a longtime speaker at this meeting, who has a new address. He moved from the University of Cincinnati, where he's now in Boston at the Mass General Hospital and Harvard Medical School. So he's about the same distance in flight, but a different location. Ken is going to walk us through metabolic liver disease in this patient population, take us through some of the new nomenclature as well, and really set the stage for helping you manage this very difficult problem in our people with HIV. Ken?
Thank you. I'd like to thank you, Mark and Mike, for again letting me speak at this great meeting. This is like a meeting I know I always look forward to and learn so much. So, we have this long, twisty name, metabolic dysfunction associated steatotic liver disease. What is that all about? And why are they doing that to us? Well, let's start at sort of the beginning. What is fatty liver? So fatty liver, whoa, moved forward by itself. Fatty liver is a liver that has more than 5% of the hepatocyte showing evidence of steatosis or fat. And we divide that into a non-alcoholic, which is arbitrarily defined as less than 21 drinks a week for men and 14 drinks a week for women, or alcoholic if there is more than that. This is sort of the way we have traditionally thought about this, and I'll say this several times, where a lot of the existing literature that we're going to use is based on. So let me go back to that for a second. If ALTs are elevated, then there's liver injury going on, and we have a disease. And if that disease it has certain characteristics, which I will show you, we've called it NASH, or non-alcoholic steatohepatitis. So that's sort of where we've been. I lost my picture on this, so I can't point at anything, but that's, if you have a way to revive that, that would be great. So the NAFLD nomenclature has changed, and the reasons for that are complicated. There was a Delphi committee, and they said, well, first, it's time for a name change. And then they met again in some nice place and said, well, we need an overarching term because both the term non-alcoholic and fatty are stigmatizing. Now, I will editorialize on that for just a second, because since this change has been made, and I have told patients that they have steatotic liver disease, they look at me with blank faces and say, what does that mean? And that the only possible answer is it means you have fat in your liver, so you have a fatty liver, so you end up using the word anyways. There could be an overarching term, steatotic liver disease, and it should include the concept of metabolic. Why? Because overall, among people worldwide who have disease of fat in their liver, steatosis, the leading cause of death is actually related to cardiometabolic complications. They then said, okay, now we need to break that down a little bit and come up with subcategories, and finally said, we're going to change the name and we're going to start using these metabolic associated steatotic liver disease terms, which was accepted by a very large committee representing multiple societies, and suddenly we had a name change. What does that name change mean to you? Nothing in most cases, except how we think about and classify things moving forward in the literature. So what are the cardiometabolic criteria? Well, they're listed here. We don't need to look right now at the pediatric criteria, but it's basically all of those things that we think of as metabolic risk factors: higher BMIs, elevated fasting glucoses or hemoglobin A1Cs, elevated blood pressure, or you can substitute, if you're already on an antihypertensive, you fall into that group, elevated triglycerides and elevated cholesterol. So those things that classically were associated often with cardiometabolic outcomes and fat in the liver are now all put together under these new universal terms. And this is sort of how it falls out. We have this broad category, steatotic liver disease. If you have one of those criteria or more, you have metabolic associated steatotic liver disease, or MASLD, and a subset of those have metabolic dysfunction associated steatohepatitis, or MASH, which we used to call NASH. A lot of people drink alcohol, and we know that, and we know that alcohol is a disease modifier. Now, there are subcategories that tell you that whether you include the mention of alcohol and you call it MET-ALD, so metabolic alcoholic liver disease, really, but if you look at the average daily intake, you could see that there's a transition of MASLD predominant here when you're drinking 20 to 30 grams a day. That's about 1.5 to 2.5 drinks. A standard drink in the US is 14 grams. Interestingly, a standard drink in Europe is 11 grams. So if you drink European wines and things like that, you get to drink a little more. And as you move up the spectrum, it becomes primarily a alcohol predominant met ald. If it's just alcohol and you don't have the cardiometabolic criteria, which is rare, then you have alcohol-associated liver disease. You could also have specific etiology steatotic liver disease, and that includes this drug-induced liver disease category. There are drugs that put fat in the liver, valproic acid, perhexylene maleate, amiodarone, for example. Or you could have monogenic diseases like a lysosomal acid lipase deficiency, or, and here's where we all come in today, miscellaneous. That includes disease associated with Hep C. You might remember genotype 3, Hep C, is highly associated with development of steatosis, and HIV. Again, if you don't have those other characteristics, if you do, then the presence of those cardiometabolic findings supersede that being a monogenic disease. And then there's cryptogenic, meaning we can't find any reason why there's fat in the liver, but there's fat in the liver, and so we're just going to call it cryptogenic. And there is a decision support tool that basically says what I just shared with you, that you start with steatosis identified by imaging or biopsy. You ask, does the patient meet cardiometabolic criteria? If the answer's yes, then you ask, are there any other causes? If there's no, then it's MASLD. If it's yes, then it's either met ALD or one of the other categories. It is important to remember that genetics plays a key role in the phenotype of the disease, and there are certain gene polymorphisms that have been identified now that appear to significantly influence the outcomes of disease. Among these, PNPLA3 is probably the most important. The gene for that is present in 30 to 40% of the US population, but is enriched in some subgroups, particularly people in Latin America, Native American populations have much higher levels of PNPLA3 gene polymorphism, leading to greater phenotypic expression of liver disease. The problem is none of these tests are yet commercially available. They're mainly research tests, so you can't at this point do testing in your patient. If we ask, how does the disease spectrum affect the natural history of disease, we see a complicated chart here, and I'm just going to show you 2 or 3 things that are important to note. First, when you identify the patient, do they have fibrosis? The more fibrosis they have, the more likely they are to move forward towards hepatic decompensation. Patients with MASLD have lower rates of decompensation than those with met ALD, and each of those categories is a little slower than pure alcohol-associated liver disease. And it's influenced, obviously, by the amount of alcohol you drink and the presence of those genetic risk factors. So what is the prevalence of disease? Well, it depends on the population studied and the definition that you use. And this is where reading the literature gets really, really complicated. So there are various ways that people define that someone has a steatotic liver. Ultrasound is the most commonly used modality, and all of you have experienced dealing with a patient that has some abdominal pain, and wondering, could this be gallstones, gallbladder disease, and ultrasound is ordered, and you get a report back that says echogenic liver consistent with fatty liver. It could be consistent with other things as well, because there are many things that can make the liver echogenic, but fatty liver is the most common, so that's what the radiologists report, and then that often leads people to say, what am I going to do now? It's important to know that the sensitivity of that is about 30% fat in the liver. So remember, steatotic liver disease is 5% of hepatocytes having excess fat in them. So there's a big gap right there. CAP, the controlled attenuation parameter that one can get in association with transient elastography on a FibroScan machine, has a relative limit of detection, or reliable limit of detection, of about 10% fat. So again, still a small miss rate. CT is also around 10%. The gold standard of non-invasive tests is MRI with PDFF, or proton density fat fraction, which will detect reliably down to 5%, with like a variability of 1 to 2% on either side of that. There are non-invasive biochemical markers. I'll show you some examples of those. And histology is, by definition, the gold standard, but requires a liver biopsy be done. And if anything, we have moved away from liver biopsies in many, many centers around the country. Which leaves us with general estimates when you read papers of 20 to 60% of the US population has steatotic liver disease. We know that it's important because we could look at the other end of the spectrum. We could say, how often does the presence of, and I'm going to use the word NASH interchangeably with MASH because all the literature up to months ago was NASH, and that's what you find in the paper, so you can't just change the word. But just in your mind, use those interchangeably. So what we see is that there's been a continuous increase in NASH-associated liver transplantation, as we've seen a multi-year decline in Hep C-associated liver transplantation. And alcohol-associated, also a steatotic disease, has paralleled that of NASH or MASH. So what exactly is MASH or NASH? Well, it all goes back to a specific scoring system that unfortunately can only be determined on a liver biopsy. So years ago, Beth Brunt, a well-known liver pathologist, put together the NAS scoring system and said, you can look at a biopsy, rate it by steatosis, lobular inflammation, something called ballooning, and fibrosis. And then if you have more than 5 points or 5 points or more, it is definite NASH. If it is 3 to 4, it's indeterminate or borderline. And if it has 0, 1, or 2, then it's not steatohepatitis. And that's important because steatohepatitis is considered the really progressive form of the disease. So all of the studies either use the straight NAS scoring or a modification of that came from an NIH network called the NASH CRN scoring system, which adds pediatric categories and some subcategories in terms of some of the characteristics, but is essentially based on the same NAS scoring system. This is what it looks like. This is a fatty liver. All those white spots are hepatocytes where everything in the cytoplasm is pushed to the side because there's a globule, a nice round globule of fat in the cell. And interestingly, this by itself is not really a disease. So we talk about fat and this overriding category of steatosis, but if all of you went out last night to a nice restaurant and ate a large meal, this is what your liver looks like today. And if you put yourself on a diet for the next 2 days because you had a great weekend in Baltimore, it will go away in most of you. If you continually eat like that to the point where your BMI rises, then this becomes more permanent. And this is just a close-up of that cells with simple steatosis. And you start to get some inflammation, some cell dropout, and a little bit of fibrosis developing. And the blue in here is very early fibrosis here seen in the portal areas. And we call that NAFLD, or now MASLD. NASH has very specific characteristics, as I showed you from the scoring system. There's ballooned hepatocytes, like that. There's inflammatory cells, a mix of lymphocytes and some neutrophils in there. And there's the fat, the nice round globules. And you put those things together and you score them on a continuous or semi-continuous scale. And that's how you arrive at this patient on a liver biopsy has NASH or MASH. And NASH is associated with a type of fibrosis that's different than what we see in hepatitis B or C. It has this fine network that we call chicken wire fibrosis. This surrounds cells individually and creates like a lattice network around them. And over time, it coalesces into regenerating nodules, and a regenerating nodule, a liver lobule completely surrounded by a band of scar, is cirrhosis. So if someone ever asks you, what is cirrhosis? That's what cirrhosis is. Everything else that we describe clinically is a result of portal hypertension associated with altered blood flow through the liver because fibrosis has reached the stage near or with cirrhosis that leads to those outcomes, those clinical outcomes. What does a patient look like up front in your laboratory tests? Well, serum transaminases are usually elevated 2 to 4 times, and the ALT is higher than the AST unless the patient is cirrhotic. And then typically we see a flip of AST higher than ALT. The ALK phos is often elevated 1 to 2 times. Serum ferritins are often seen as elevated as well. And albumin, bilirubin, and INR are normal until late in cirrhosis when hepatic decompensation occurs. Now, we need non-invasive markers because we can't and won't do liver biopsies on every person that we get a report on saying they look like they have a fatty liver. So how do we do that? And various schemes and scoring cutoffs have been developed with different algorithms. The most commonly used is to simply look at TE with CAP, just like we do in hepatitis C. FIB4, which all of you have used also in Hep C, has the variables age, platelet count, AST, and ALT. Remember, that says nothing directly about liver fibrosis. It says that if the liver is scarred, blood flow is altered, platelet counts go down, AST and ALT reflect inflammation, and the older you are, the more likely you are to have injury. There is the NFS, or NASH fibrosis score, which is basically the FIB4 with the addition of BMI and the presence of diabetes as well as an albumin. in a complex algorithm, but you can get it on your smartphone. And it gives you a score that says, is there significant fibrosis? If there's significant fibrosis, then you probably have NASH as opposed to simple steatosis or NAFLD. The problem with this test is that an awful lot of people fall into that indeterminate score and leave you scratching your head. And as you'll see in a little bit, most of the current guidelines say time to think about getting a liver biopsy. And the FAST score is a combination of the TE with CAP and the addition of AST as a marker of inflammation, but at least there are cutoffs that give you a better probability of there's actually NASH present with an NAS score of 4 or more. And you'll see in a few minutes why that probably will be important going forward. So what about in HIV? Well, there's a number of studies out there, but there is now an NIH-funded HIV-NASH CRN network that both Dr. Sikowski and Dr. Nagy are part of. And they recently published a study, the first study, I think, from their group that got published since it was created, that took 1,065 persons living with HIV, all on ART more than 6 months, excluded viral hepatitis and excessive alcohol use, and measured the liver stiffness, FIB4, and the NASH fibrosis score. And now you know what each of those things are. Their key findings, well, 77% were overweight with a BMI of greater than 25 or obese with a BMI of greater than 30. 6.3% by these measures had advanced fibrosis, which would be F3 or F4, and 52% had steatosis, which was determined as a CAP greater than 263. So pretty high levels of steatosis seen in that population. They looked at receiver operator curves for sensitivity and specificity of some of those markers relative to the FibroScan and set cutoffs using the receiver operator curve. And you could see that while the specificity was quite good for advanced fibrosis, the sensitivity was awful for both FIB4 and for NFS. So, you know, maybe that already answers a question. Many of you have access now to FibroScan with CAP, and that's probably what we should be using in this field. So what are the key questions? Well, is steatosis more common? And I'll say maybe, because some studies actually said that in the setting of HIV, steatosis was less common, but this study, which took a large number of patients that were selected by the criteria that I showed you, said it was over 50%. That's more common than many studies show in the general population. Is MASH or NASH more common? Most studies say yes, it is. Though at CROI 10 days ago, Jenny Price said, but fibrosis was more common and ballooning less common, suggesting that that's a different answer. So it's really a maybe. Does ART influence risk? And the answer again is maybe, but mainly through INSTI-associated weight gain. Are mechanisms underlying disease the same in persons living with HIV? And I would say at this point that is unclear. The finding, again reported by Jenny Price, of increased fibrosis with less ballooning would suggest that other mechanisms may be involved. And are leading candidate drugs effective? And I would say at this point, despite some of the data I'll show you or tell you about, that remains unknown. So when you think a patient has significant liver disease associated with steatosis, what are we going to do? We need to approach targets of opportunity, and those are obesity, inflammation, apoptosis, fibrosis, oxidative stress, or metabolic control. I'm going to show you some data from some of those categories. So obesity drives a lot of this, and you saw how common it was in the HIV cohort that I just described to you. And we control that with diet, exercise, drug-induced weight loss, or bariatric surgery. There are NAFL guidelines from the ASLD that say weight loss reduces hepatic steatosis with a 1A rating, which means it is so. The loss of 3 to 5% of body weight improves steatosis, but you need 10% loss to improve necroinflammation, the inflammatory component. And exercise alone may reduce steatosis, but the effect on liver histology remains unknown. They go on in that guideline, which remember was just last year, just before they changed the name, and so they're still using NAFLD and NASH in it. Patients who are overweight should be prescribed a diet that leads to a caloric deficit. When possible, diets with limited carbs and saturated fat enriched with high fiber and unsaturated fats, a Mediterranean diet, should be encouraged due to additional cardiovascular benefit. Patients with NAFLD or MAFLD should strongly encourage to increase activity level whenever possible. And the bottom line is weight loss improves steatosis, NASH, and hepatic fibrosis in a dose-dependent manner. Also interesting, coffee consumption, caffeinated or not, of at least 3 cups daily is associated with less advanced liver disease. So go out and drink your coffee. Bariatric surgery should be considered as a therapeutic option because it does work, and I'll stop there. But what we really want is, we know those things are difficult to have, either get surgery or simply lose weight by telling a patient to lose weight. So we want to treat some of those other approaches. You could treat oxidative stress, and the products available are vitamin E, phosphodiesterase PDE5 inhibitors, or VAP1 inhibitors. Vitamin E is the only one studied in a large clinical trial in this group, a randomized trial. The PIVENS trial looked at patients without diabetes with NASH, vitamin E 800 units a day for 2 years versus pioglitazone versus placebo. Pre and post-treatment liver biopsies were performed. Vitamin E was superior to placebo. Pioglitazone failed to meet the endpoint and resulted in weight gain, but liver enzymes went down. There's a bunch of target candidates in the metabolic category. FXR antagonists like obeticholic acid, PPAR agonists, GLP-1, sterol coenzyme A desaturase inhibitors, or RAMCOL, had a very positive phase 2 and phase 3 trials, but the company pivoted to working on PSC and didn't pursue FDA registration. Thyroid hormone receptor agonist, I'll show you some data on, and I'll mention growth hormone releasing hormone because this is tesamorelin, an agent that is approved in HIV already and had positive results on NASH and fibrosis in the setting of HIV in a phase 2 trial, but has not yet been taken to an active phase 3 trial. Obeticholic acid was studied in a large 4-year trial, and I show you the data here because it's instructive for what I'm going to show you in a moment next as comparison. You see that that if we look for improvement in fibrosis with no worsening of NASH fibrosis or NASH component scores, we saw an effect in up to 23% of patients in intention to treat and somewhat higher in per protocol. It did not succeed in NASH resolution with no worsening of fibrosis. This drug went to the FDA and was not approved. It is approved for treatment in PBC, so it is potentially available off-label. It was not approved for safety concerns, particularly in patients with advanced disease. Saraglitazar is a dual PPAR alpha-gamma agonist, did well in a phase 2 in terms of ALT. Phase 3 trial is underway. Semaglutide, GLP-1 agonist, you heard some discussion about that yesterday. This is large phase 2 study with 72-week duration, 320 liver biopsy confirmed NASH F1 to F3 cases, multiple doses compared to placebo. The primary endpoint of resolution of NASH without worsening fibrosis was achieved. The secondary endpoint of fibrosis improvement was not achieved. That's opposite what we saw with obeticholic acid. I'm going to come back to that concept at the very end. It significantly caused nausea, vomiting. That's part of how you get weight loss. It increased amylase, lipase, and some decrease in GFR was seen related to dose. A second study was recently published in cirrhotic patients. So again, fixed fibrosis. It did not meet its endpoint. It didn't work. But 10 days ago at CROI, we saw the results, the initial results of the SLIM liver trial, phase 2b single-arm open label trial in persons living with HIV, dose escalated semaglutide because of the tolerance issue, 24-week total duration. They used MRI, PDFF, read by a blinded central reader. Wasn't a big study, 51, 49 completed, but there was significant fat decrease and there was weight loss. So for this group of patients, it works. Actually, it works just like in everyone else. It causes weight loss. Resmetirom. This is a thyroid hormone receptor agonist. Large phase 3 trial published just weeks ago in the New England Journal. It met endpoints for both criteria, as you can see here, the blue line and the orange at 2 doses versus placebo. So this is one that met both of those types of endpoints that we talked about. It was safe and well tolerated, and it was approved by the FDA 2 days ago. We haven't seen the label yet. The company announced that biopsies will not be needed, though they only enrolled people that met biopsy criteria. We'll wait to see what that shows us. It has not been studied in persons living with HIV. This is the clinical algorithm that AGA has. There's a number of clinical algorithms out there. Basically, it says, if you think your patient has fat in their liver, you should do FIB-4. If the FIB-4 is elevated, they're considered high risk. Send them to a hepatologist. If they're indeterminate, send them to a hepatologist and get a liver biopsy. If they're low risk, follow them with non-invasive tests and continue to encourage weight loss. So in conclusion, new terminology designed to decrease stigma and recognize the important role of cardiometabolic associations with fat in the liver are now available, and we should be shifting to the new terminology. Increased disease recognition is needed. New treatment modalities are coming. One new agent is approved for at least the general population, but it's clear that multi-target regimens are needed. And what I think we're going to evolve to is going to be based upon stage of disease. If you simply have early MAFLD, then you need weight loss. And perhaps drugs like GLP-1s will be the best way to achieve that. If you have fibrosis, you're going to need something that's going to affect the fibrosis stage, either alone or in combination with other agents. Stop there. Thank you.
Well, thank you, Ken. That was a wonderful overview of this new terminology and new therapies. Really is remarkable that there's finally an FDA-approved drug for what I'll call NASH, because it's a lot easier to say and more comfortable. But it's certainly an interesting area, and that once again, we're seeing major advances in a field where people with HIV have not been studied, yet the drug is on the market, leaving us to try to ask the question, are there any concerns about antiretroviral therapy? Are there concerns about its efficacy, safety, tolerability in people with HIV? And here we are with an approved product and waiting on studies. So I think it really is important that we look at these things early. Well, we'll change gears now, and I'm really thrilled to welcome back Dr. Glenn Treisman, known to those of you who have attended OPMAN before, professor of psychiatry and medicine at Johns Hopkins, a longtime psychiatrist at our HIV clinic, and for many years had the privilege of sharing a Monday afternoon clinic session where Glenn and I were both in the practice at the same time, and really have had the privilege of working with him for the last, well, I won't even say how many decades, Glenn, but it's been a while. And he's going to take us through the treatment of addiction for every clinician, a really important discussion. So Glenn, I'll turn it over to you.
We have been working together a long time, and you don't look any older than when I met you, and I definitely look older. You'll notice the title is For Every Clinician. The reason is substance abuse is ubiquitous, and there aren't enough substance abuse-ologists out there to treat most of your patients, and most of your patients won't go. And so if we want to fight this epidemic is HIV and hepatitis C epidemic, hepatitis B epidemic, then we have to treat substance abuse. And you've gotten used to doing everything. This is one more thing to do. One of the things to know about is this. Most medical people are extremely pessimistic about the outcome of substance abuse. And that part of it is that you guys are introverts. You're very consequence averse. You worry about making mistakes, and you tend to notice your failures more than your successes. And that's a problem with substance abuse because you see the people who come back still using, and you don't notice the people who stopped. And that's a liability. We did a study at Hopkins where we got people very excited about substance abuse as students, and then we surveyed them after they finished, and they had lost a lot of their excitement about substance abuse. The reason they lose excitement is they don't see their successes as well. But we're very successful with treating substance abuse. About a third of patients will get chronically sober if you treat them. And that's a 5-year study we did, all comers, about a third become sober. Now, a lot of them relapse in between before they get to sobriety, and it is a chronic relapsing illness where you have to be all over the patient. But by year 5, most people were sober, 34% or something like that. So as a huge number of people get better. Now, you can say, well, it's only 34%. If I could cure 30% of hepatocellular carcinoma, how would I do? That would be really good. So this is really good. I want to talk about what addiction is. I want to talk about the disease models and behavioral models of addiction briefly, and I want to talk about a framework for thinking about addictions in your practice. So I have no conflicts of interest because nobody will hire me to do anything except academic work anymore. This is one thing you need to know. This is deaths from HIV versus deaths from drug overdoses. And this is a 2017 data, so it's old, but the OD thing has gotten worse, not better, since 2017. Just so you know, it's important. This is national overdose deaths by year to 2021, and you can see that synthetic opiates lead the way, but there's a huge number of deaths in our population of patients from drug use, and alcohol exacerbates that. So our patients are exposed to lots of addictive substances, and then they have vulnerabilities like personality and social supports, and structural elements like work, hobbies, exercise, religion, income, and then they get major depression and chronic mental illness and intellectual ability that all are risk factors when you're exposed to drugs for developing an addiction. And then you get entrainment, that is, you develop a habit of using drugs. So there's this exposure to the drug, a set of vulnerabilities that make you more likely to get, if you use, pardon the infectious disease use, infected, and then a set of things that make the infection entrained. So the group of people who get entrained get conditioned and develop cues and conditioning to use. And I'm going to talk about that. It's important for us to think about in our work. This is patients with HIV, and it just shows that they're more likely to be exposed to every kind of drug you can imagine. I have all the drugs listed on the edge, but you can see cigarettes and tobacco, alcohol, marijuana, cocaine, heroin, hallucinogens, inhalants. They're exposed to lots of drugs, and our HIV-infected patients are more likely to have been exposed to drugs even before they got infected. Past year use of drugs, dependence use of drugs in HIV versus HIV positive people, obviously the HIV positive are much more likely to use drugs. 11-fold increase for heroin, for instance, there, and a 6-fold increase for any illicit drug. Alcohol is only 2-fold, but still, even alcohol. So our patients are at risk for using drugs, and when they use drugs, they get addicted to drugs. So when I was starting my career, there's this huge effort to make addiction a disease. And on the test, for whatever board you take, addiction is a disease. That's the answer they want. And the great thing about that is it destigmatizes substance use. We tended to think about drug addicts as bad people. One thing I just want to mention the word drug addiction. People who are drug users refer to themselves as addicts. It's their word. It's an important word. We want to shy away from it because we want to destigmatize addiction. But they want you to recognize that they have a really bad thing, which is an addiction. So I use the word addiction, even though there is a gray zone between when you're overusing and when you become truly addicted. And I'll talk about that a little bit. But there's a volitional component to addiction that's absent from other diseases. That is, with schizophrenia, which is a disease, if I had a drug that had no side effects that you could take and you wouldn't have schizophrenia anymore, patients would take it in a second. In fact, neuroleptics, which don't cure schizophrenia and are horrible to take, most of them take at least a substantial part of their antipsychotics. We have a drug for heroin addiction called naltrexone. If you give people naltrexone, they don't use heroin because taking naltrexone, you don't get any high from heroin anymore. So people will stop using it. The problem is no one will take it because there's a volitional component. Most patients will say, I use heroin every day because I'll go into withdrawal if I don't. All of those people have had a period of sobriety where they weren't using heroin and went back to heroin. They didn't go back because they were in withdrawal. They went back because they get high when they use it. And the getting high part gets missed a lot. The second thing is treatment needs to emphasize rehabilitation rather than just medication. So if you have pneumonia, you don't have to get rehabilitated. You have to take your penicillin. If you're addicted to heroin, you have to get rehabilitated. You can't just give somebody buprenorphine because they don't get better and they'll go back to heroin. And lastly, behavioral models are better than lesion models. So a lot of diseases, you can lesion something in the brain and simulate the disease. You can break something and the person will look like they have that disease. In alcoholism and drug addiction, behavioral models are better, and I'll show you something about them. So when I say addiction, I mean a behavioral pattern of continuing use despite increasing consequences that distorts all elements of function over time. That's So when does that happen? When does somebody go from being a little excessive in their use of alcohol to being an alcoholic? And one of my patients drove through the wall of his house, parked in the living room, got out of his car, peed into a chair like it was a toilet, lay down on the couch and went to sleep, and came to me the next day and said, well, I'm not an alcoholic. I said, when are you an alcoholic? When you park in the kitchen? I mean, when is the line? The line is when you continue to use and tell me the next day you're not an alcoholic after driving through the wall of your house. So if people use despite increasing consequences, you have to think about addiction. And the core concepts of that are tolerance, that is, you need an increasing dose to get the effect, dependence, some kind of withdrawal, reinforcement, so the drug will make you want to use it more, and behaviors associated with using the drug will increase. So people who use alcohol to excess will want to drink alcohol in the same environment, in the same glass, with the same brand, more and more. The behavior gets more and more stereotyped and reinforcing. Animals and people will work to get the drug, that is, they will self-administer the drug. Animals will press the lever to get the drug. Animals will not press the lever to get antibiotics. They will not press the lever to get antidepressants. They will press the lever to get addictive drugs. And animals will self-administer and people will self-administer despite increasing consequences. So with animals, give them an electric shock, they'll still press the lever to get the drug. This is the part of your brain that does drug addiction. It's the ascending mesolimbic dopamine pathway that I always talk about. It's the sort of yeah circuit of your brain. And you can see all the different addictive drugs all impinge on this reward pathway. It's the major reward pathway that gets you out of bed every morning. And what addictive drugs do is they short circuit all other behaviors to get you quickest to a yeah in your life. And so that's the thing we have to contend with, because that's going to continue. This is from Thorndike in 1913. The probability of a behavior can be increased or decreased depending on its immediate consequence. This is part of the behaviorists that started working around 1900. There was Thorndike and Pavlov and Skinner and all those different people who studied animal behavior and modeled human behavior on it. Watson, you guys have heard of him. He was kind of a bad guy, but very interesting behaviorist. So if I wear this tie, and Solkowski says, wow, that's a great tie, I'd probably wear it more. And he said, did you get dressed in the dark this morning? I'd wear it less. And so that's simple reinforcement. If you get benefit from it and a positive reward from the environment, you'll do it more. And if you get electric shock, you'll do it less. It's not very complicated. So this is learning 101. This is how we learn. And but for some things, there's this cycle in which you do a behavior, you have an opportunity to do a behavior, and when you do it, there's the environmental response I just talked about, where it's bad or good. But for some things, the behavior itself will release dopamine in your brain, and that's reinforcing. And then you get satiated, and then you get a craving for the behavior, and you do it again. So think of a baby. The behavior is crying. Milk pops into your mouth. Milk. And then you're satisfied, and the baby doesn't want to eat anymore. And then he gets hungry, and he cries again. And this is an amplification loop. And after a while, you say, if you want dinner, you have to wash your hands, and you have to eat with silverware. And you can't wear that hat backwards at the table, or whatever you say to your kids that screw them up later. And this cycle is an amplification loop. It's very dangerous in biology to have amplification loops. They exist, and they're incredibly highly regulated. So for most of the behaviors that do this, eating, sleeping, and sex, which are the behaviors that do this, there's a turnoff. You've had enough, and you don't want any more. Eat enough, you don't want any more. Sleep enough, you don't want any more. Sex, you don't want any more. Some of us less than others. I have a really big cycle, by the way, in my brain. So this cycle is dangerous. It can lead you to be chubby. I know this. So why is it there? So how many of you have ever been food poisoned? Raise your hands. When did you think you'd eat again? I heard it. Somebody said never. That's a person who's really been food poisoned. Because when you're in hour 3 of vomiting, you say, I am never eating again, and you mean it. And the next day you say, well, maybe some plain toast. Toast. And maybe some plain pasta. Pasta. And pretty soon, you're eating normally. Because if this cycle wasn't there, and you never ate again, you couldn't join us here today. Because if you think back 100,000 years, no refrigerators, no Zaggett's Guide, no little book of which mushrooms to eat, a lot of hungry people eating things that they probably shouldn't eat. And you got food poisoned a lot more back then. And if you never ate again, you were selected against. This was selected for. Same is true with sleep. Probably none of you have had the pleasure of having your house on fire while you're sleeping, but I can say, you say, I'm never sleeping again. And same thing is true with sex. Most of you have dated somebody really horrible, and you can say, never again, and really mean it. But after, a year or so, you find the right person, and life is perfect. My right person's over there. She rescued me from this cycle ruining me. So this cycle is what drives addiction, because there's no turnoff for addiction. And it short circuits all the other behaviors. Now, as you think about this, there are elements that make you more likely to get exposed to drugs. The kind of person you are, the life you have, and whether you have depression or other diseases, you're more likely to take drugs. And those same things are more likely to continue that cycle. This is Joe Brady's baboon. He's sitting in a cage. When the light comes on the left, if he presses the lever, he gets food in that little box up on the top. When the light comes on the right, if he pushes the lever, he gets the drug that's in this little syringe. And baboons will push the lever to get drugs. They'll push the lever about 50 times to get food if they're hungry. If you set it at 500 times, they go hungry till you feed them dinner. Baboons know they cost $30,000, and you're not going to let them starve to death. If you set the thing on 500 and addict them to heroin, they will press the lever up to about 500 times to get heroin. Set it on 750. They go cold turkey and wreck your machine and maybe hurt you. And if you put cocaine in that syringe or amphetamine, they'll press the lever 5,000 times for cocaine. Cocaine is the most producing drug there is. And the reinforcement of behavior is incredibly powerful. So it's studied a lot in these kinds of studies. So here's the actual baboon. This is a slightly different cage. You can see there's two levers. There's door number 1 and door number 2. And behind door number 2 in this study is cocaine. And baboon doesn't even notice door number 1. It might as well not be there. And he's waiting for the light to go on. And you can't really see it, but right in this dish where the food comes, there's a little bit of banana-flavored candy that baboons really like, and a normal baboon would have eaten this. This is a cocaine-addicted baboon. He won't eat that little bit of powder because he's waiting for his Coke. So these addiction models are very useful because they do tell us kind of what people will do. They're very predictive of what people will do. And so if you're a person who has major depression, eating, sleeping, and sex might not be rewarding, but drugs still are. If you're a person who likes instant gratification because you're a now-focused, feeling-driven person, you're more vulnerable. In terms of alcohol, some people genetically have more of this with alcohol than others. They're more likely to become alcoholics. In terms of cocaine, everybody gets the same reinforcement, but some of the genetics for risk-taking behavior will predict that you're more likely to get addicted to cocaine. So this is open to the environment. And so things like genes, social connections, religion, occupation, class, geography, social conventions in your environment. Now what happens if you have one of these? Well, more and more as this cycle goes around, you lose work, hobbies, exercise, sleep, the normal activities of life. And they go away from your life, and all you become is an automaton looking for drugs. You want to get people better, you have to build those back in because this cycle predicts behavior. There's no rewards, you won't do anything. So here's my little rat, and he's in this cage. He only has one lever and 2 lights. And when this light comes on, he gets food from here when he presses that lever. And you can train him to do that. And then after a while, when this light comes on, he gets cocaine. When this light comes on, he gets an electric shock. He'll try it a couple times, and then he's done with it. Now you put the rat in here for a while, and you turn on both lights. And what do you think will happen? About 14 to 15% of rats will press the lever anyway. 85% won't. By the way, there's a parallel experiment in Vietnam. We looked at people who use drugs every day. This was Robbins' work back in the Vietnam era. Most people who went to Vietnam who used drugs every day, when they came back, 85% of them stopped using, 15% continue. It's about the same kind of thing. There are animals that are very easy to entrain in this kind of experiment. Other animals, if you give people enough cocaine long enough, or animals enough cocaine long enough, they'll all press the lever to get cocaine when this electric shock is on. But it takes much more for some animals than for others. This is the same study. Thank you. Oh, I thought this was a gin and tonic. SAG would have brought me a gin and tonic. So what predicts relapse? If you turn that machine off so that the animal's not getting rewarded, take the animal out of the cage after a while and put him back in, even though the thing's off, he'll go over and try it some. And he'll not try it very much. However, if you stress him, he'll try it 10 times more. If you make him depressed, he'll try it 10 times more. If you give him a little teeny bit of drug, not enough to keep him to reinforce use, he'll go and use it 10 times more. And if you play music while he's using and then turn that music on, which is a cue, environmental cue, he'll do it 10 times more. So those are the things that lead to relapse, right? People, places, and things that we tell patients to change that are cues for relapse. And so those are the relapse triggers that we have to contend with. So what are you going to do about these patients? What can we do for them? The first thing you have to do is you have to do a thing I call a role induction or confrontation or identification of the problem. Patients have to recognize that they have a problem, that they have an addiction, and their ability to deny that is intense. There are different ways to do role inductions, but I'm going to talk about it just for a minute. The second thing you got to do is detoxify them. If that animal's in the cage and the light is on, you cannot change his behavior. So you have to get people out of their use cycle. You have to get them out of their environment. Sometimes that means admitting them to the hospital. Other times it means getting them to a place where they're safe. But it always means that you have to interrupt the current day-to-day use some way. Third thing you want to do is rehabilitate people. That is, you have to put back in rewards from normal activities. And all the people in their life have moved on. You have to get some people back in their life, either those people. It's amazing how families will forgive a person who's gotten sober and celebrate them and be positive about them. Now, at first they won't believe it, but they will forgive people and people can get their family back. And they're so gratified when that happens. Last things you have to treat their comorbid psychiatric disorders. If they have depression, you'll never get them sober without treating it. If they have the kind of personality and temperament where they have to live in the now and only look for rewards, you have to help them manage that. And relapse prevention is the thing. Since this is a relapsing illness, you have to plan for what they're going to do when they relapse. So I say to patients, I'm always going to drug test you. And they say, well, don't you trust me? I say, I trust you now because you're sober. But when you're using, you can't trust you and neither can I. And I won't know when you've relapsed except by testing you. So I'm going to test you. So you just, when you come in here and you relapse, just tell me because I'm going to test you anyway. And you almost never have to test those people because they always tell you. But you have to be willing to test them or they won't tell you. Because when they're using, they're an addict. And when they're not using, they go back to being a person. Conversion or role induction, confront people with a smile. There's motivational interviewing where you can say, basically, the core of motivation is how's that working for you? But you talk to people about what they're struggling with and what's bad, and gradually they'll come to the place where they say drugs are ruining my life, or you can just say, I think drugs are ruining your life. I'm much more confrontational in that way, but I think each person has their own best style, and each patient responds to their own best style. So I've read a lot about motivational interviewing, which is you drag it out of the patient. Better for introverts. My clinic, a lot of extroverts, they're better with bong. You have to talk about your goals versus the patient's goals. Longevity, function, and quality of life versus comfort. I want to feel better today. You can't feel better today. You can get better today, and then you'll feel better tomorrow. And some people will say, there is no tomorrow. I say, probably there is, because you had yesterday, there was today. And so getting people to the place where they recognize that the goals of treatment are function, quality of life, and longevity, and not feeling good. This is what everybody wants. Everyone wants to feel good. They want a shortcut. They want me to give them a drug that makes them feel good today, and tomorrow they'll deal with tomorrow. Borrowing money from a loan shark. Not good. So you explain the role of the doctor and the patient, what the diagnosis is and what the goals of treatment are. firm limits combined with advocacy. I will do anything to get you better. I will do nothing to get you out of trouble if you're not going to get better. Focus on problems in the patient's life and focus on behavior and rehabilitation and away from feelings. Patients want to talk about their feelings. Say, of course you feel terrible. You're a drug addict. When you're not a drug addict anymore, which can happen, you'll be a person in recovery, you'll feel a lot better. So let's talk about what you're going to do and not about how you feel, because they all feel terrible because they're early in treatment. So in this cycle, you want to get people to stop the behavior. So the X you want is here. Confront behavior. When patients say, I couldn't come to clinic today because I was too busy, you say, I wasn't too busy and I'm not the one who's sick. I'm not the one who's homeless. I'm not the one who's in trouble. I'm not the one who has gonorrhea. So confront behavior. Can't means won't, need means want, and think means feel. Patients always say, I can't go to group today because I can't get out of bed. I say, well, if I hit you with a fire extinguisher, could you get out of bed? Then they say, well, yeah, then I could. So you don't mean can't. You mean I won't go to group today. But you won't say that because then I would discharge you from the hospital. So I think you should just go to group. They do. Stop the behavior, prevent withdrawal, treat potential accompanying diseases, and detoxification is key. You have to get the toxic substance out of the person's body and get them through the withdrawal period. If you let them go halfway through the withdrawal period, the data is they will relapse every time. So if you say, well, we'll just get you 3 days through the withdrawal, and then it won't be that bad, you can go home. No, 2 more days, because if they're still withdrawing, they're going to go out and use. You want to stop both the internal craving and you want to stop the drive for using. And that's what that step does. Pharmacological treatment for withdrawal, active tapers and suppressing certain symptoms, clonidine, non-steroidal anti-inflammatories, methocarbamol, antihistamines, they all are useful. Alpha-2 drugs like clonidine are particularly useful in helping people with opiates and benzos get off, people with alcohol withdrawal getting off. We underuse on clonidine because you worry about the blood pressure drops. The thing I'm worried about is the blood pressure drop that you see when people use fentanyl, because that blood pressure drop's irreversible. Usually the blood pressure drops to 0 and stays there in those patients. So everybody tells me, well, I can't give any of these things because this person's an active drug addict. Don't worry, they're giving things that are more poisonous than what you're giving. Try to get people off. And you want to stop the internal drive. And if they're in withdrawal, they have an internal drive. You want to rehabilitate people, damage control, talk to the family, try to get them into a place where they can live. Environmental change, people, places, and things. Extinguishing the habit means giving a new habit. People don't stop doing something, they start doing something else. You have to give them something else to do. Occupational therapy should be included, social, physical, and psychological therapies, all part of rehabilitating people. And you're trying to put back in eating, sleeping, sex, work, hobbies, and exercise into this cycle, which is what keeps most of us from getting into that cycle in the first place. We're all somewhat vulnerable, but if you have none of those, you're much more vulnerable. People tend to get addicted when their structure falls apart. So in the transition from high school to college or work, where there's suddenly the structure goes away, or in their 50s when they lose their job finally, or their wife or husband finally leaves them, or their family finally says, we're done with you, and people just go off the rails. Adjunctive pharmacotherapy, treat psychiatric comorbidities, but the other things you want to do, substitute addiction, methadone, buprenorphine, you heard about them briefly. These are drugs that really help, they're agonist therapies, they really help suppress cravings for opiates. You can block reinforcement with something like naltrexone. There is a drug in trials right now that dramatically decreases cocaine and amphetamine cravings. There's 2 candidate drugs that I know about that aren't in trials yet, but I'm trying to help get into trials. Drive suppression and then symptomatic treatment for withdrawal. Those are the pharmacotherapies, and they stop these 2 things also. And then treating comorbidities. Depressed people don't get any yeah from anything, and drugs will still give them a yeah. You have to treat depression. My data shows that between 20 and 30% of the patients in your clinic have depression. When I published that back in the early 90s, everybody laughed and said, well, that's just at Hopkins. And then they said, oh, it's everywhere. If you look for it, you see it. If you don't look for it, you don't see it. You're paid not to look for it, because if you see it, then you have to spend more time with the patient. And that means your day gets slowed down. So you're incentivized to ignore depression. Don't. Attend to the life story, try to remoralize people, manage their temperament. I just said this, addiction still goes, but depression will block rewards from normal activities. This is a concept that most of you don't think about as much, but introversion and extroversion are dimensions of human temperament, like height. There's short people, average people, most people are average, and tall people. There's nothing wrong with being tall, nothing wrong with being short. Short people outlive tall people. They have less injuries and falls. They survive cold better, thirst better, hunger better. They are more built for resilience. Tall people can outrun us. They can shoot better basketball than us, and they get to be the president. Not all tall people get to be the president. Not all presidents are tall, but by and large. And most people are in the middle. And in the middle, say, you know, you're pretty good at both things, but you're not great at anything. No one ever should go up and say, hey, you should go out with me because I'm average. It's what's special about you on these curves that makes you who you are. And introversion and extroversion are one of these things that are distributed normally. Introverts, how sensitive you are to consequences. Extroverts, how sensitive you are to rewards. Introverts, how much you're directed at the future and the past. Extroverts, how much you're directed at the now. Introverts think about function, sit in this meeting so they get something out of it, even if it's a nice day out. Extroverts, all about feelings. They don't come to clinic because they didn't feel like it. It's a really nice day, I didn't come to clinic. One of my patients said, I took a mental health day. I said, no, you took a mental illness day. Mental health is when you come here, okay? Out there is mental illness for you. So you have to recognize your patients are extroverts. As introverts, if you read the writings of the guy who did this, a guy named Hans Eysenck, he doesn't like extroverts. He says they're neutral traits, that introverts and extroverts are neutral. But as he describes extroverts, it's pejorative, and as he describes introverts, it's laudatory, because he was an introvert. And he thought a lot about this. And the extroverts don't think a lot about this because they don't care about you. They're out busy having fun. Extroverts have more fun than us. They do. They have more fun. However, they get addicted to heroin more than us, too. So there's no bad place on this curve, but there's a bad place in this curve to have chronic illness. And there's a bad place on this curve if you're addicted. However, extroverts are exquisitely reward sensitive. You being nice to them is rewarding for them. They like it. They will respond to your positive input. Don't be mad at them. Ignore them when they do things you don't like, and laud them when they do things you do like. And you'll be amazed at that. It's not salient for you, but it is salient for them. It makes a huge difference. I'm not going to take you through all this stuff, but this is a study where we paid people to use less cocaine. If you didn't use cocaine between this visit and the next visit, we give you more and more money. It's called incentivized sobriety. And when you do this for a year, people use less cocaine because cocaine addicts are very sensitive to rewards. They tend to be very extroverted. And so this is very powerful for people who are addicted to cocaine. Really works. And their cardiac plaque regresses in 1 year, enough to pay for giving everybody the money. So if we just did this for everybody, we would actually save money in terms of cardiovascular costs, not including crime and homelessness and depression, all the other stuff, just cardiovascular costs, because the soft plaque regresses in 1 year. This is essentially the study, and I won't take you through it, but it works. And it's better, though, for cocaine than it is for alcohol, because alcohol tends to get a lot of introverts, too. So incentivized treatment is more effective. Paying people who are cocaine is more effective for cocaine. It works in alcoholics who are extroverts. It doesn't work as good in alcoholics who are introverts. They need to be yelled at more. So barriers to addiction treatment for doctors, the time you have with the patient. It takes a lot of time. I don't know a way to make it faster. I don't. You have to sit with patients and talk to them. And you have to persuade them. You have to do the role induction. You have to rehabilitate them. You have to meet with them every week. You have to see them a lot. You have to nurse them through the treatment. Knowing the infrastructure, you probably don't know all the drug treatment options in your area, and you have to learn them. They are there. Even in the worst of environments, there's people out there trying to stop the drug epidemic, and it's causing the HIV and hepatitis C epidemics, so you need to hook up with it. If you are hooked up with it, great. If you're not, you can be. People will be glad to help. Lack of resources, getting help with tough cases, very hard to do. Someone asked yesterday in the session, what about tough cases? I said, you got to get people to help you and you got to go talk to them. And lastly, the general pessimism that I already mentioned about drug treatment outcomes. You do well, patients. So there's very little integrated care in our world of hepatitis C and HIV. That is, we tend not to have a psychiatrist in our clinic. But I'll tell you some cool data. I asked SAG yesterday, what did you say, 86%? Yeah. In his clinic, where he's there, it's this great SAG, 86% undetectable. In our clinic, 96% undetectable. Our parallel clinic in DC, 66% undetectable. Why do we have more? Because we have integrated treatment. We have substance abuse, we have psychiatry in the same physical clinic as we have hepatitis C and HIV treatment. Makes a huge difference for that group of patients. And that's the group of patients most likely to get infected, to transmit infection, to not take your medicines, and to drive you insane. And if somebody like me in the clinic, I can help you not be driven insane. Thank you guys for inviting me again.
Well, we've got about roughly 10 minutes for questions. I'm keenly aware that we're standing between you and a lunch break, so we won't extend beyond that. First of all, Glenn, I want to thank you for a really wonderful talk. And I'll say that, I don't get the chance to work in the same afternoon with Glenn anymore in the clinic, the Bartlett Clinic over at Johns
Abandonment
Hopkins.
issues. It's caused abandonment issues. He left me.
But what I was going to say, Glenn, is that these little tidbits, I carry them with me in all of our patient interactions and apply them as I'm interviewing patients and trying to treat them. So these kind of stories that they really stick with you. And I suggest you bring them into your clinic and try just to practice as you're interviewing and treating your patients. There's a lot of information there that I find really useful.
Thank you.
So, thank you.
Thank you.
Or you can come and spend time with Glenn in clinic.
That's right. You're all welcome. And if you want to come spend time with me in clinic, it's a lot of fun. SAG did it.
So
He's still recovering.
We've got a few questions that came in online, and welcome those here to come to the mics. So these, Ken, we'll start with you. A person with, let's say, Hep B, Hep C, or metabolic liver disease, how often should their liver disease be staged? Let's say it's cured, well, maybe just take all three, because I think they're probably a little different, maybe, but maybe not. Is there such thing as an annual liver disease assessment with FibroScan or something like that?
So in part, it depends upon the stage of liver disease when you begin looking at them. Patients with advanced fibrosis, cirrhosis should undergo ultrasound every 6 months for HCC screening, so regardless of the underlying cause of disease. So those are 6-month intervals. If you have a patient that you're following for an interval like in the algorithm I showed you for patients with MASLD, then probably every 2 to 3 years for repeat FibroScan would be very reasonable. It's not sensitive enough to pick up shorter interval changes in general.
Well, let me ask you a specific question. It comes from my clinic. I've got some patients who are no fibrosis with Hep B on treatment. So ALT is, let's say it's 12, very normal, no fibrosis. And there is a desire to look frequently with repeat testing, whereas, I generally think what you said, we should do it at some interval of 3 to 4 years. What's the longest that patient can go, or do they really even need further assessment of fibrosis if they're on treatment and suppressed?
So if their ALT is 12, and ALT is considered a pretty good marker of inflammation. Inflammation leads to fibrosis. You probably don't need to be re-looking at them if they didn't have advanced disease from the start.
Thanks. I'll tell them next time I have that, I'll bring that back to the clinic. So let's go to the microphone. We have a question here in the room.
Yes, I tend to ignore marijuana since the legalization with patients, family, friends. Can you comment on that?
not without getting beaten up. Marijuana is an addictive drug. The rats will push the lever to get it. So alcohol is legal, and so I don't ignore alcohol. I don't ignore marijuana. It's a risk-benefit issue. People are smoking marijuana on Friday night or Saturday night. It's like having a drink to me on Friday or Saturday night. If they're doing okay, that I don't worry about it. If they have a PO2 of 60, I do worry about it. And so you're trying to look at the whole patient, but alcohol is addictive. And although it's not as addictive as cocaine, it accounts for more deaths because it's legal. And marijuana is moving in that direction. So we have to be thinking critically about how we talk to patients about marijuana. Someone comes to my clinic reeking of marijuana, I tell them that I can't see them because they're intoxicated. And psychotherapy is very ineffective in people while they're high. So what you do with a particular patient depends on what you can assess. Many patients will say to me, well, my marijuana isn't a problem. And then you bring in the person they're living with, and they say, she's spending all our money on marijuana. We don't have any money. Then it turns out it's an issue for the other person. So I think you do have to interrogate people a lot about marijuana and their use. I think you can decide it's recreational in the sense that it's not causing problems. And you can drink, I think that there are a lot of people who drink safely, and alcohol isn't particularly addictive for them. But people who get addicted to alcohol are ruined by it. So I think the same is true with marijuana. The guy who's the world's expert on marijuana self-administration and use is a guy named Elliot Gardner at NIDA. And he has shown in his, I think he has 3,000 papers. In his 3,000 papers, he's shown that it's addictive in a very compelling way. And everybody wants to pretend that he didn't, but he did.
All right, well, let's go to Dr. Sag on my left.
Dr. Sherman, just a couple questions for clarity about the thyroid hormone receptors. Mm-hmm. So first thing, when I think of a thyroid hormone receptor agonist, I think of thyroid hormone. How is this different than just simply giving T3 or T4?
It's more targeted, apparently, in terms of its metabolic effects. I'm not sure that I could answer you mechanistically.
Which was a follow-up question.
Yeah,
I'm
yeah.
having trouble understanding how that helps fibrosis, which it clearly does from the data you showed. I'm just trying to figure out how that might work.
Yeah, excellent question.
Another unknown on the list of, okay.
So I was going to ask you a similar question. In that study where people didn't drink, where you excluded alcohol drinkers, did you test them for long metabolites of alcohol?
You're referring to the cohort.
Yeah.
The cohort study.
Yeah.
I don't believe that they did, but Mark is one of the investigators.
Yeah, it's an interesting question because there is a test, PETH, that is available. And we actually did a couple things. We did 2 questionnaires about alcohol, including audit, and then we pulled samples just recently and tested for PETH on that cohort. Yeah. And we actually found in this particular cohort of people that the PETH results in general were consistent with what we recorded on the audit. Mm-hmm. Now, in another study we did at Hepatitis C, we found there was complete disconnect. People had underreported alcohol. So
yeah, those must be my patients. That you're
well, I think there are some differences in, there may be some differences in the people that we were enrolling in those studies. But yeah, we did some PETH and that analysis going on now, but it's increasingly used. Our transplant teams are using PETH now, and it's increasingly used. So let me go to the microphone in the room, and then Ken, I have another question for you. So, but let's go to the microphone on the right.
Yes, thank you. My name is Hubert Sindri from VIV. So, Dr. Sherman, I'm a little focused on those patients with the cryptogenic state of disease. I mean, I'm worried that these patients could be missed.
The monogenic diseases, yes.
So how do you determine when the liver disease is alcoholic or non-alcoholic? Is there a test? I heard Dr. Trishman mentioned something just now.
Yeah, that's a great question. I mean, in most hepatology clinics, as opposed to infectious disease clinics, we do a pretty thorough workup for other etiologies of disease. And if it seems warranted, we have easier access, I would say, to biopsy, which often helps separate those disease processes. And I think that that's reflected in the guidelines that say that those patients that have more advanced disease probably should see a hepatologist.
Yeah, so the treatment options that you discussed earlier, is there any treatment recommendation for someone with just, ketogenic or non-alcoholic liver steatosis as compared to someone with advanced disease or the weight loss or, and other non-pharmacologic option that you discussed, are they sufficient?
So,
what
yeah.
is the follow-up after?
So it depends again on the etiology. If your patient had Hep C genotype 3, you would treat that patient and you would cure the steatosis with the cure of the Hep C. If they have a lysosomal disease, then there are treatments for that as well, and it would just have to be identified. And you're probably not going to do the routine testing for that. In general, advanced fibrosis that you can't explain deserves some additional follow-up and workup.
Great, we'll go to the microphone.
Yes, how are you? Very good presentation. I have two kind of practical questions. At what point, as an infectious disease, I'll have to refer to you, especially when it's NASH, and all the infectious disease causes has been ruled out? Number one. Number two is the new drug. I didn't listen to that. It's for NASH. Is for non-cirrhotic patients, if I do understand. And who can prescribe that? Do I have to give it to refer to a hepatologist, liver specialist? Thank you.
So it was approved Friday. So we have not even seen it. Once a drug is approved, there's usually a month to 2 month process where the sponsor, the company, works with the FDA to develop the product insert, which specifies those types of items. And then beyond that, the decisions about drug restriction, especially for expensive drugs, end up coming down to the payers and making that decision. This is too new for us to know that at this point. In the study that led to the approval, patients were F1 to F3. So it's likely the approval will be for F1 and F3 through F3 disease. And they did say that a biopsy will not be required to make the decision, meaning they're allowing use of non-invasive markers to determine who is a candidate for the licensed approval. But I think we'll all have to wait a few more weeks to see what that actually looks like.
Great, we'll squeeze in one more question.
One comment and one question. One more tool that we can use with our patients regarding marijuana is that the recent study came out from the NIH where they studied over 400,000 smokers, daily smokers of cannabis, and they found a 40% increased risk of cardiovascular disease and 20% increased risk of stroke. That's any smoke going into the lungs is toxic. And I wanted to ask Dr. Treisman, what recommendations do you have for crystal meth users as far as medications?
Well, I'm hopeful that by a year from now, we will have the first drug that decreases cravings for amphetamine. But amphetamine is unbelievably destructive and rapidly destructive to people. So you got to get people away from meth. What's interesting is that the intense cravings for methamphetamine tend to wear off reasonably quickly as well. So if you can get people away from it even for a week, often, and they're ready for treatment, they're ready to engage, you can do pretty well with them. Some people think that topiramate, Topamax, which is an anticonvulsant, is useful in the craving part of methamphetamine. Other anticonvulsants sometimes are good. I used to use a lot of dizipramine in cocaine and amphetamine users. Sometimes that's very helpful. But we don't really have great pharmacotherapy yet. We're surprisingly effective, though, if we can get people into treatment. People will get away from their meth friends. They do pretty well. But they have to be ready to give it up. There's not enough resources for treatment. And those people engaged in meth, I mean, that is such a vicious use cycle. You really have to get people off the street for a while. Sometimes you can do okay with alcohol or opiates by having people go to group, but boy, meth, you just got to get them someplace away from it for a while before their brain comes back.
Well, great. We're going to wrap up the morning session there. We'll take a break for lunch. For those of you attending in person, lunch is outside. We're going to ask you to reconvene with your food at 12:35 Eastern Time. We're going to work through some cases, so we'll take a lunch break. For those of you at home, 12:35 Eastern Time, we'll be back and work through some case presentations. So thanks for joining us for the morning. We'll be back for cases in about 20 minutes. This is always one of my favorite parts of OPMAN because we get a chance to really think about practical ways of how we would optimally manage people, which is where the OPMAN comes from, optimal management. So I've got some cases put together. We'll try to get through as many as we can before we end the virtual sessions and break for our roundtables. So let me invite all of our Sunday speakers up to the stage here. We have a seat in front of their nameplates, and we'll go ahead and get started with some cases. And our speakers can bring food up too, it's okay. I don't see Dr. Treisman, but he'll be up shortly. So we'll go ahead and dive into it. Okay, so we'll start with a patient that I actually recently saw, a 6-year-old man, born in Ghana, West Africa, presents with a newly diagnosed Hep B. He's got hypertension. He had never had prior testing, and he requested blood work after his sister was diagnosed and treated for chronic Hep B. And taking a history, he's unaware of his mother's hepatitis B status, but she did die at a relatively young age of an unknown cancer. So his workup is depicted here. He's got a viral load for Hep B of 7,900, so not high, but also not low. He's e antigen negative, his ALT is 32. He's got a very high surface antigen level, and I'll ask my panelists at some point, should I have ordered that? Minimal liver disease, negative for Hep C and HIV, and his liver ultrasound was unremarkable. I get a lot that come back and say echogenic liver parenchyma, which drives me crazy. This one actually came back and said unremarkable, truly normal. So we'll start with a relatively what I think is a simple question. We talked about Delta today, or HDV virus, but should I have screened him for HDV? Shyam, I'll start with you since this was your topic.
Sure. Yeah, so like 2 years ago, I would say no, because we didn't have anything to offer. So you tell somebody, hey, you have another terrible disease that I cannot do anything about. And I think we have not had really great success from geographically in the United States to test people for Delta and say, hey, if you're from Baltimore, you can test and then you're likely to be Delta positive. We don't have that at all. But now that you do have options and Delta is occurring in patients who are from the geographic area that he is from and he already has chronic hepatitis B, even though his ALT is normal, or I think it's 32 level, I think, Delta, I think is slowly moving into, it's not a definite yes, but it's slowly moving into the workup of chronic hepatitis B because now we have something to offer. The reason why we do all these things, even though treatment is optimal, is because Delta virus is the most aggressive form of fibrosis. If you do have Delta virus, then the patient has to be monitored closely, or if you have available options to be treated, because that's going to have a very rapid progressive disease. One caveat, though, is that ALT is normal. If you have Delta active infection, your ALT should be elevated. That's a sign, something that so you could wait and see if what happens to the ALT, a couple of more numbers on that, and before you go and test delta. But I'm more for yes.
So maybe we can have a show of hands. How many of our panelists would test this person for HDV? So a fair number. And I recognize I did not ask the audience to vote, but now we've had the sort of expert input here. So I think we've kind of, it's like an open book test now, so we'll skip that voting. And I just wanted to mention that the EASL European guidelines say screen everybody with S antigen positivity for HDV antibody, whereas WSLD screens by a complicated list over to the right of this slide, which there's some discussion about should everyone just be tested, because we know risk-based testing based on geography and behaviors is a difficult pattern for people to engage in. But they do recommend people from West Africa be screened. All right, so now we will vote on the next question. For some reason. All right, here we go. So let's go back to his, so he's HDV negative. He does not have Delta. His viral load is 7,900, so that's above the 2,000 threshold. His ALT is 32. We can talk about whether that's normal, but would you recommend antiviral therapy for this patient? And we'll go ahead and open voting, but there's a yes is the 1 through 4 with different options, and 5 is no, I would not recommend treatment. So go ahead and vote, and then we'll get our panelists' input.
Wow.
So 90% wanted to treat, and they selected sulfalfenamide. And 2% said no. So really, if you add them up, it's 98% wanted treatment. So Devika, I'll start with you. What would you have done in this individual where he's in the so-called gray zone? His viral load is higher than you'd like it to be, and his ALT is 32-ish, which is that normal? And go ahead.
Yeah, thanks. So just one quick question. Do we know his GFR?
Normal.
Normal. Okay. So I agree. I would treat. And I'll tell you, I have, one thing that I tell house staff is I have cognitive dissonance when I start screening for HCC, because he would qualify for screening for HCC given his age and his ethnicity and his hepatitis B, even in the absence of cirrhosis. So cognitive dissonance with screening without treatment. And so he is in the gray zone in the sense that although he's antigen negative with a viral load of greater than 2,000, his ALT is just at the cusp of normal, right? 19 and 30 with the new ALT, newish ALT levels to define normal. So I would treat because he's 60, he is, and we're going to start screening anyway.
So Ken, let me ask you, ALT has been kind of, you talked about a normal ALT, and then there's the issue of what is a normal ALT, and the US guidelines, I believe for men they pick 35 and women 25, but other guidelines say 2 times upper limit of normal. There's all kinds of advice about it. What is a normal ALT for a veteran hepatologist like yourself, Ken?
30 for a man, and that's based upon a receiver-operator curve developed in a large population. Like any other type of curve, there's a little variation around that on either side. 35 was decided by a consensus group just sitting in a room with people saying, I do 40, I do 25, oh, let's pick 35. And so if you biopsy this person, work from Mindy Wynn and others suggests that there's a high chance he will have active inflammatory disease, and particularly with that level of viral replication.
So you would be hesitant to classify him as a normal, no liver problems. Mm-hmm. So maybe in the interest of time, I'll move to just on a bit. So the consensus was to treat this individual, and I think that's one of the areas that as the Hep B guidelines get reworked for the modern era, that we'll try to, I think, really need to decide what to do in the gray zone. And Deborah, I liked the dissonance around the screening for liver cancer. So let me ask the next question. And you kind of spoiled this one. I'm just saying, but that's okay. Should he initiate surveillance for hepatocellular carcinoma? 1 through 3 is yes, but you get different options to select from. Ultrasound plus AFP, ultrasound only AFP, or no. So go ahead and vote. So 53%, 55%, 54, ultrasound plus AFP. Ultrasound is the number 2. So most people want an ultrasound. I think we add that up, we're at 96% want ultrasound. So, maybe we'll, Susanna, I've not asked you a question yet. How would you approach this patient?
Yeah, no, I mean, he clearly meets criteria for surveillance, and I think ultrasound is a definite. The guidelines have gone back and forth on whether or not serum alpha-fetoprotein changes the sensitivity of a screening approach. So I think ultrasound, without a doubt. I think different people have different practices. I do not use ultrasound. I mean, I don't use AFP, but a lot of people do. So I don't think either of those are wrong. AFP alone is problematic, although there's a recognition and there are data looking at the role of AFP alone in extremely resource-limited settings where ultrasound is not available, suggesting that if AFP alone is better than nothing, but if you have access to ultrasound, that would be the preferred surveillance strategy.
So we'll talk about Ken, what's your view on AFP? And that's you as...
Yeah, I mean, I would get the ultrasound with AFP, and I think most hepatologists in the U.S. choose to do that, not because AFP specifically is a great marker, but a change in AFP often leads us to use a more sensitive imaging modality. So it's important to establish your baseline and then follow that, remembering that ultrasound is really only sensitive down to about a 1 centimeter lesion. And in places where there's not a lot of experience in finding HCCs, it's a very subjective test. And so an AFP that's bumped up, even with a negative ultrasound, will prompt you to use a CT or MR.
And
Let me...
Can I ask Ken a quick question? So what change in AFP or absolute AFP do you use to look further?
Yeah, I mean, if it bumps up 10 or 15 points, you say, oh, we're going to follow that more closely. And if it bumps up 40 or 50, we go straight to the biphasic, multiphasic CT.
Well, great. I did want to share that just recently the AASLD, which is the Liver Society, updated their guidelines. And over to the left of this slide talks about which people they would recommend for surveillance. You'll see for non-cirrhotic hepatitis B, men 40, age 40 that is, and women age 50, with some predilection to screen more people born in Africa, family history of HCC. So they tell you sort of who to screen. Perhaps C, it's really the cirrhotic patients. And then over to the other side of the slide, they actually talked about endorsing AFP again, which is a bit of a comeback for this test because about 10 years ago they dropped it. There was a lot of pushback, and now they put it back in. So the recommendations are for every 6 months based on studies showing that that picks up small lesions that can potentially be treated. Let me jump ahead.
Make one point. I think getting an ultrasound for a chronic hepatitis B patient in the community is a very difficult task because it depends on your insurance, everything else. As you know, hepatitis B patients populations are very different. Many of these people are don't have insurance, they're not documented, and we find it ourselves very difficult to have that $200, $250 per paid by the patient. So it's yes, recommendations are there, but actually in reality, many of those people actually do not get that. So I think that's something, I just want to pass it on that we want to make sure that these people do have the opportunity to be able to means to get that ultrasound for them.
So Glenn, I'll ask you a question, because a lot of times we have a lot of trouble getting people to follow up with their surveillance of ultrasound. It's kind of a pain, right? You got to take time off work, you got to drive into ultrasound, you got to fast, these type of things. Particularly people cured of Hep C, because they hear you're cured, all's good. So just trying to apply some of the lessons you taught us this morning about, how we improve uptake of surveillance for things. It's not just for cancer, but what are your thoughts on that?
I offer people small amounts of cocaine if they get their scan. No, it's a great question. So we have a patient who will see me, but won't go see his primary, won't go see his liver transplant doctors. I diagnosed his hepatocellular carcinoma on a CT. I got him wedged. They wanted to do a transplant. I said, this guy will get kicked off the transplant list. They said, no, we'll be fine. He got kicked off the transplant list. I got him wedged, did great for 3 years, had recurrence, but by then got a transplant. But I have been holding his hand. And to get him to get an ultrasound, I will have to go over with him. I'll say, just take him over there myself, because that's the only way he'll do it. So if you think it's, at some point you say, this is really important for this guy who's had one recurrence already and tells me he's lost 15 pounds, this is the latest thing, I walked him over there. He didn't have anything on ultrasound, and eventually I'll probably get him CT, but his weight's gone back up. They're tough. The really difficult patients are tough, but I think that encouragement, positive reinforcement.
I thought you were going to tell me cash incentives, but we have a question here at the microphone.
Can you just clarify screening in, like, say, chronic hepatitis B in non-cirrhotics?
Yeah.
Because I thought it was every 6 months if they're chronic Hep B.
It is. So if you look at what the recommendations are, surveillance for liver cancer, and I tell patients it's the same principle of mammograms. For cirrhotic patients, everybody. For non-cirrhotic, it's categories: men older than 40, women older than 50, persons from Africa, and then persons with a family history of HCC. So, and then the PAGE score includes things like ALT. So it's really not everybody. So a 20-year-old, you wouldn't start surveillance quite yet. I don't know that it's wrong to do that, but I think the cost effectiveness models indicate that the incidence over in that middle column has to be higher than that threshold to recommend the incidence of cancer, that is. So it's based on incidence in that group of people and the cost effectiveness of these modalities. But let me jump ahead and talk about another case. We've touched on the idea of pregnant people, and this is actually an individual I saw recently, 31 years old, early second trimester, a newly diagnosed Hep C, actually was screened by her obstetrician as part of the screening recommendations. Believe she was affected probably in her 20s through a very brief period of injection drug use that's not currently active. The workup is as below. ALT is 13, which Ken will tell me is normal. The liver fibrosis panel is nothing going on there. Hep B is negative. Genotype 1A, 762,000 international units per ml is her. So she's got active hepatitis, and really is referred during pregnancy to discuss options. So what would you recommend? Defer treatment to the postpartum period, treat with lead-soft, treat with Sofvel, treat with glicapavir/pibrentasvir, or deliver by C-section? Go ahead and vote. So Suzanne, I'll ask you to start with this one since you delved into these issues. I know you thought about it.
Right. So I think what I would say is that we know that people that are pregnant do not require C-section delivery. So that would not be correct. I think the rest of this really comes down to a conversation with the patient. So as you all know, the FDA has not approved a regimen, as I mentioned, in pregnant people. The most data that we have has come with lidopisphere sofosbuvir in terms of PK data and early safety data that's given in the third trimester after organogenesis is complete. That there is an active study that's ongoing. Catherine Chappell, who's the lead PI for that, she's OB-GYN at Pitt. I think they've enrolled over 40 people now into a study that will enroll 100 total pregnant people. So we will have data, more data, but I think ultimately this really does come down to, I think there's a general feeling by many people that in the third trimester after organogenesis, these drugs are likely safe. That this really is a critical decision between the medical provider and the patient. I think some people would defer, given that it's not yet approved and the guidelines do not yet say that there's sufficient data for safety to recommend it. But I also know that there are providers who are doing it because they have patients who are adamant that they want therapy. And That's kind of where I am clinically in terms of how I'm approaching it.
So Devika, in Hep B, it's pretty clear now that tenofovir during pregnancy for pregnant people with Hep B, we'll put HIV aside because that is universal, but it's based on viral load. So you've thought about this quite a bit. What are your thoughts on how you counsel this patient about the pros and cons of antiviral therapy?
Yeah, I mean, I largely agree with Susanna. I mean, completely agree with Susanna. And I think it's really about a discussion with the patient. I feel comfortable enough that after the first trimester, I would feel comfortable in treating. And I would pick either Sofvel or Lead-Sof. Just so you know, there's also another DAIDS network impact trial that's being designed to look at GP actually in pregnancy. So I think we'll have data soon. The way the guidelines word it is very carefully worded, but they do say it can be considered with conversation.
Let's jump ahead to the next slide. Let me try that again. Okay, so we did just that extensive discussion with her and her partner, and decided we wanted to initiate treatment as soon as possible. And it went from like sort of thinking about to do it now kind of thing. We talked about clinical trials, and as much as she appreciates the work you all are doing, she is not interested in a clinical trial. So let me go to the next one, which I think is a question. So would you prescribe antiviral therapy in this scenario? You've heard two of leading experts in this area, but let's just see who would actually write the prescription. It's time to go into Epic and order it. So would you do that, or would you still have concerns about comfort? And it's a simple question, yes, no, maybe. So about 75% are yes or maybe, and 26% are no. And I think just about 25% are no. And I will share what Devika just talked about. She is the spoiler of my slides here today. But I did think it's helpful to look. On the right, you've got the data from the single published study, 9 patients with Lead-Sof, all did very well. And the guidance on this is that last bullet point, which says, despite the lack of a recommendation, treatment can be considered. So I think what you saw reflect on the voting was some of this discomfort with a lack of a formal a formal recommendation from the society. So I'll ask, let me ask our panelist, given that she and her partner both want treatment, how many would treat? We had about, so we're at 75.
I'd ask you.
What's that?
I would ask you.
Well,
and I would talk to her for a long time, and then I would walk her over to your office and sit down.
You probably would, actually. I think he's not kidding, actually. That's what's funny about that.
Yes, the good thing about you being in the clinic sometimes.
So Ken, I'll ask you to weigh in, because I think I didn't see Ken's hand go up. So we were at about 75%, the same as you all.
Yeah, I mean, when I was in Cincinnati, we were part of one of the multi-center trials on this. So I would encourage the patient to consider the trial entry and say, we're not going to offer it to you outside of the trial, because that's how you enroll trials. And otherwise, I think that I would wait. I mean, I got embroiled a few years ago in one of the treatment for Hep B before drugs were approved, and it just, until there's some data, more than the 9 patients, I think that in that setting, there's no harm in waiting.
So our audience vote is not bad. Well, you got your wish, Ken, because I did prescribe therapy for her, but the prioritization took over 6 to 8 weeks. And in Maryland, we still have prior auths. So she really couldn't start therapy before delivery. And they have a healthy child about 1 month ago. So consideration of treatment, actually wrote a prescription for her, but it's a situation kind of like the people you admit in the hospital. We do the same thing that they're doing in the VA. The problem is, so we've got someone who's going to get endocarditis treatment in a long-term care facility for 6 weeks. The problem we run into is I write the prescription, the prior auth kicks in, the patient gets discharged, And then sometimes they leave, they make a self-directed discharge from the rehab center. So we really have had trouble getting the prescription turned around in time before they get discharged. So I guess I don't have a question for the panel. I'm just speaking about the evils of prior authorization. I'll leave it there. Okay, so let's talk about her baby, who is now born. I'll ask our panel before I pose the question, what would you quote her for the risk that her baby acquired hepatitis C during this pregnancy, viral load around 7,600 HIV negative? And we want to quote her a number? Where you guys are like confirming before?
Group science.
Replacing
group
a bet.
science. That's right.
5%.
Team science, yeah, up to 5%.
Up to 5%. And higher
Higher
in
in
people
HIV,
with HIV.
up to 10%.
Yes.
Yep.
Okay, and that's the number I quoted her, so that's I'm glad to hear my colleagues agree with me. So let's go to a vote. What would you advise her about the pediatrics? So we just told you there's about a 5% risk. So 1 is no testing, 2 is HCV RNA testing at 2 to 6 months of age, 3 is antibody 18 months waiting for the maternal antibodies to go away, or 4, initiate treatment for the baby as soon as feasible. So go ahead and vote. The majority, 2/3, would like testing between 2 and 6 months. What do our panelists think? Would RNA testing for this baby or wait for antibody? This is where like no one wants to look at me because I know I'm calling them, you know? Ken, what would you do? What would you?
RNA testing afterwards, there's passive transfer of antibody. It's going to be positive for a while, so that's not useful at all. And you want to know if there's active disease.
So I think it's a timing thing, right? So if you really want to know now, RNA testing at 2 to 6 months, but you don't really care about that because then you want to wait, you can wait for antibody test 18 months of age. That's just the timing.
Yeah. So I wanted to highlight a new recommendation from the CDC, which is outlined here. You know, they're really, you know, if you think about it, and Susanna shared this data, we have more children getting Hep C today than, you know, really so that number of kids getting infected is actually going up because of the rates that you saw earlier. So they actually moved forward to recommend nucleic acid testing, PCR, between 2 and 6 months. And the other side is if they, for some reason they don't get that, do the antibody, but wait a year and a half for the reasons Ken said. The shift here is in part because in some parts of the United States, some states, coverage is really pretty good in the first 6 months after delivery, and then it tails off for mothers and infants. So I'll leave it at that, but the recommendation shifted to do testing. All right, so we'll try to squeeze in a few more cases. So this is we talked about this one, but given the questions we had, so 48-year-old man with HIV, he is on a 3-drug regimen, including sulfalfenamide and tricytidine. He wants to switch to a long-acting injectable. His data is shown there. He's S antigen negative, core antibody negative, S antibody negative. He was vaccinated 15 years ago, noting his CD4 nadir was only 195. We don't know whether he responded or not, and there's no post-vaccination testing. So a question is how you would manage him. If you decide to recommend another round of HPV vaccination, what would you recommend? 1 is the 3 doses of the standard. 2 is 3 doses of a 3 HBs antigen vaccine. And then 3 and 4 are the Hepatitis B or TLR9 agonist vaccine, either 2 or 3 doses. So go ahead and vote. This is in part a test of how closely you were paying attention to Dr. Bhattacharya's presentation. So go ahead and vote. Okay.
All right, okay.
So Debica, I've got to start with you. What would you have done?
Yeah, I mean, I think I am compelled by the proportion of antibodies greater than 1,000. And in this particular patient who is going to remain at risk for hepatitis B, I would do 3-dose.
Sean, let me ask you, this the B got not very popular, no one voted for it, But this is a vaccine that's got antigen. It's a pre-S1, pre-S2, and then what are your thoughts on that vaccine, if it's got any value or if you're using your practice? Jim, I'll start with you, yeah?
Yeah, no, I have no experience. It's not something that I worked on. I don't think, compared to all these other options, I don't think it is not going to have any role.
Ken, thoughts on that?
Well, there's, in the setting of HIV, there was one 39-patient study, and it was not as good as what we've seen with Heplicab, so I don't think that there would be a reason to choose that.
So we're at 95% with the new vaccine, and I would, let me go, let's see if I thought I had a slide tucked in there. Let me go back one. One thing I wanted to point out this slide, you saw these data, I won't belabor it, but in the people with CD4 counts that were low, you know how you always worry when someone's CD4 is less than 200? They actually did a lot better with that third dose. That's one group that really responded well to the third dose. So another potential, consider their immune system when you're thinking about 2 or 3. So I'm going to go on to another case. We had a lot of questions about this. This is actually a patient I saw recently, a 56-year-old man, psoriatic arthritis, that wanted to start a anti-TNF therapy. He has prior Hep C, documented, treated, and cured in 2017, F2 before he was treated. He's currently RNA not detected, although he got to me because they checked an antibody, which was positive, and they were concerned the hepatitis was active. He wasn't referred for his Hep B, but when I went back to look at his, he was actually referred for the Hep C antibody positivity. I went back and looked at his testing that was done around the time of Hep C treatment by a skilled clinician, and they checked, and he was core positive, anti-HBs negative, E antibody positive, DNA was not detected at that time. So we touched on this one quite a bit, but we'll go ahead and vote. So what would you recommend at this point? One is HCV prophylaxis with Sofvel or GP. 2, 3, and 4 are HBV prophylaxis with oral drugs, and you can pick your favorite. 5 is no prophylaxis monitor, and 6 is advise the rheumatologist to select a different way to treat their psoriatic arthritis. So go ahead and vote.
Does he have psoriasis or the heartbreak of psoriasis?
Well, it's an interesting set of votes here. Livia, I'm pleased to see, got no votes. That will fall off any recommendations. About 25% want to monitor. A fair number want to treat, or prophylax, I should say. And some, 6%, want to worry about Hep C reactivating. So let me start with that one. Hep C reactivation in this setting.
No, there is, you don't need to worry about Hep C reactivation in the setting.
There's no latency,
Right.
there's no latency,
Right.
there's no integration.
There's enough data on people who have received chemotherapy, or et cetera. After achieving SVR, it's quite stable. Once you've cleared HCV, there is no later lapse.
Reinfection, yes. Reactivation.
Reinfection, definitely.
Reinfection, yes. And he was checked for reinfection. But I think the point is that these are cures. There is no viable virus in patients who are cured. So let me ask our panel, we talked about this quite a bit. How many people would elect to prophylax with either entecavir or tenofovir or to monitor? Deborah, you raised your hand.
Or monitor.
Oh, I thought you were asking for a show of hands.
Oh, okay. Well, no,
but I'm happy to also answer. I mean, I think so. This is the one situation where we have data and a black box warning, actually, for treatment with antiviral therapy, even for core antibody positivity. So if you remember, if you look at Rituxan, for example, there was a black box warning issued by the FDA because of deaths associated with core antibody positivity, well, with hepatitis B, and that included both surface antigen positivity, but also importantly, core antibody positivity. So definitely needs prophylaxis. I was interested to see that you gave us all these options, and I was wondering if there was a reason behind that, because I would probably, in this person, pick entecavir just because of his age and, you know, the risk of potential bone and renal side effects later on.
Yeah, I'll comment that I often use entecavir because of its free of bone or kidney problems. But Ken, the other, they were deciding between methotrexate and the TNF therapy or anti-TNF therapy. They decided against methotrexate because it might be liver toxic. They liked that as a first-line agent, but concerned about the liver toxicity. So,
Yeah, so methotrexate is probably not hepatotoxic in long-term chronic use, the way it's used in either psoriasis or rheumatoid arthritis. And a lot of that went back to the early studies, which were contaminated with significant alcohol use. We now have a pretty large experience that says that it's not a significant concern. Acute methotrexate in certain cancer settings is acutely hepatotoxic, but those are extremely high doses. We don't know what the agent they were going to use here. There are at least a dozen guidelines related to Hep B reactivation, and they are not all the same. I think the AGA guideline is the most nuanced in terms of risk stratification, and I tend to use that. And I think this patient would probably fall into the moderate, which says that monitoring would be appropriate.
yeah, I think of anti-TNF and then anti-CD20, which rituximab is sort of just do it, just give them treatment.
Yeah, I wasn't just, I was joking, but there's psoriasis and then there's really bad psoriasis. And I see a lot of patients with these autoimmune dysautonomia syndromes, and psoriasis plays a role in those. So sometimes you really kind of have to treat people.
So I'll tell you what happened here. I didn't actually see this guy because he no-showed. So I called him and did a telephone visit with the code for telephone only because he did get on video. And we had a conversation about it. So I didn't see his psoriasis, but the rheumatologists were pretty impressed reading their note. All right, so I just wanted to emphasize, Debica mentioned this, but every person 18 years and older should get the triple panel test. They recommended core exactly for this reason, to identify people who have resolved infection that might reactivate. So I won't belabor that, but that is the official recommendation for screening, slowly uptaking around the United States. So we'll do another case. We touched on these as well, but to reinforce, this is a man with HIV and Hep B on tenofovir for a long time. He's interested in changing ART to a regimen that does not include tenofovir. He's gotten older at 65. He and his healthcare provider are looking to potentially switch to an oral regimen or a long-acting injectable. His numbers are below. He is still S antigen positive, antigen negative, antibody positive, DNA not detected. S antigen is 25, as in 2.5. The lower limit of quantification is 5. No fibrosis and a liver ultrasound is normal. So which of the following regimens would you feel comfortable recommending for him with close monitoring? Keep him on tenofovir, don't switch. That's number one, is continue. 2 is dolutegravir, lamivudine, getting a little bit of a bad Hep B drug and lamivudine there. You would let him take cabotegravir, rilpivirine, long-acting, or something else. So go ahead and vote, and then we'll get our panelists to weigh in. So 83% want to continue. A good chunk are comfortable with the rilpivirine, which would essentially be a stop nuke trial, right? So let's hear, let me ask our panelists for a vote, just to get how many people would continue tenofovir-containing ART in this patient?
There's one caveat. Entecavir is an option if he wants to come off with tenofovir, right?
But you would give him something. So how many, and how many people feel comfortable? So C is essentially a stop nuke experiment in a patient with a low S antigen level, going 25. How many people would feel comfortable with this strategy, which is practiced in some parts of the world, not the US that typically, but how many people feel comfortable with this? Anyone have tried stop nuke in their practice? Ken?
Yeah, I mean, I tried, but both my experience and the data says that your chance of relapse is high, and about a third of those will even have seroreversion. So,
So, Sean, you mentioned the idea that we could potentially measure HBV RNA and maybe correlated antigen and tell if he's actually making that S antigen from integrated, which means nothing left to reactivate, or from CCC.
Right.
Now, first of all, can I order those tests today? And second of all, would they help? Let's say they were both negative.
I think they are, at least a core antigen is available through Abbott. I think RNA is homebrew, or you're going to have to, collaborate with someone to actually do it. I think there are more and more data coming in that can help you if you really want to stop. It's not somebody like this, even if someone who has lost S antigen and with as quantitative S antigen is quite low, and you're really still going to stop this person. This data would help you. Unfortunately, there is no cutoffs here. So I don't know how much it will be helpful unless you're serially following this person. You cannot really say, okay, this is like this. It's undetectable. Sure, you can, the predictive value that it would not relapse is not there. But if you have high, then they're likely to have a bad relapse. That's the data it looks like. So if you really see very high levels of RNA and correlated antigen, then you should not stop. But if it is low, you're still in the same boat. You're just not going to help you with that information. They're going to help you with stopping.
So this is obviously an area of active discussion as more options become available that are nuke sparing. I think you heard pretty strong consensus among our panelists that for people who are S antigen positive to continue the recommended therapy. I won't belabor the stop nuke therapy, but I will say there are a lot of papers published on this because some patients lose S antigen. The problem is in the bottom, which is of the people they stopped, 8 of them had an ALT flare 10 times above the normal range. You're talking the hundreds. It's a dangerous proposition to an increase in bilirubin. So I'll mention this because you hear it discussed quite a bit, but it's not something endorsed.
And, we should probably add, too, that much of that data is not in people with HIV.
None of it's in people with HIV.
Yeah,
So I just wanted to highlight that the guidelines haven't changed. Perhaps some people on this panel will be thinking of those guidelines, but they haven't changed in terms of the recommendations about if you're Hep B positive, you should be on a tenofovir-containing regimen. All right, we'll try to squeeze in one more case. We touched on this as well. HIV Hep B, taking a single tablet regimen. Over the past 5 years, she's mostly HIV less than 200, but had a peak of about 10,000. DNA is got as low as 400 once, but it's ranged anywhere from 120,000 to 100 million. She's E antigen positive. Liver stiffness is about 10.2. So let's go ahead and vote. So what would you recommend? Continue current ART, add entecavir, add interferon, add a capsid assembly modulator, or something else? So go ahead and vote. We talked about this. You guys can vote. I'll just talk while you're voting. So we talked about this idea of that there's some incomplete adherence. In this case, it's pretty obvious that there's times where the treatment is not being taken. This is a person that lives pretty far from our clinic, so some of the things we do for adherence aren't necessarily available. So let's see the responses. So most want to continue, 45% say continue current antiretroviral therapy, and a good chunk want to add something else, entecavir being available by prescription today, and 10% would like that CAM, the capsid assembly modulator, a new mechanism of action. So let me do another sort of vote sort of thing. How many people would add entecavir? So I'm not seeing any hands, and none of our panelists are adding entecavir. And it kind of gets into, I assume, that the problem is that she's not taking the single tablet she's already got, and now you're going to add a second tablet to it, and now it's 2 tablets to remember to take every day. So,
well, and not only that, but although resistance is not developed to tenofovir, it does develop to entecavir, and so you don't want to lose that agent.
Yeah, that's a great point. So tenofovir resistance. Let me ask you a question. How many people have seen tenofovir resistance in use for Hep B in their practice? So not a lot. It does, it's got an incredible high barrier resistance for Hep B. But in tenofovir, it's particularly if they've got lamivudine experience, can be a problem. All right, I'm going to squeeze in one more.
Wait, what did you do, though?
case.
What did you do?
Oh, let me go back. No, we did not add anything. Let me go back and try to squeeze in one more case. So we actually left her on that therapy and really embarked on adherence techniques with a local pharmacy. Literally, clinic is 3 hours away on the other side of Chesapeake Bay. Those of you who know the area know that the Delmarva Peninsula is a little bit of a, well, I'll just leave it there. It's really, healthcare delivery is much more difficult on the other side of the bay. And that's what we're trying to do, is get her better adherence support from nursing on that side. All right, we're gonna do one last case. I know the folks were saying, wrap it up, Solkowski, but we'll do one more. This is a 54-year-old woman with HIV, cured Hep C, increasing ALT and AST levels, hypertension, diabetes, not on medication, cured in 2014. At that time, she weighed 152, had a FibroScan of 9.2. No CAP was available then. Today, her FibroScan is 7.5. CAP is 298. ALT and AST are kind of high. Weight has gone up. Daily alcohol use, 1 beer. And of course, at least where I practice, you have to ask what size is that beer? And it turns out to be 24 ounces, which is 28 grams of alcohol. And she recently started atorvastatin based on the Reprieve trial. They wanted to get her on a therapy. I recognize that's not the one study to Reprieve, but that question came up yesterday, probably okay to use that. So what's the most likely cause of her liver enzyme elevation? 1 is drug-induced liver injury due to the statin. 2 is alcohol-related liver disease. 3 is metabolic dysfunction-associated steatotic liver disease, or MASLD. Or 4 is that combination that Ken talked about of MASLD plus alcohol, MET-ALD. None of these really just roll off your tongue, do they, Ken? We need to work on that. But go ahead and vote, and then we'll discuss it. NASH kind of rolls off your tongue, you know?
Yeah, I wasn't on that committee.
I'm struggling here, yeah. So most people think that she's got combination, well, most people, they're not blaming the statin. They think she's got both metabolic and alcohol. So Ken, you talked about this. Well, first of all, let me ask you about statins and liver toxicity, because it just never ends, that concern. What is your thought on statins and liver toxicity, particularly in this group of patients for whom a lot more people should be starting statins?
Yeah, so statins will cause a dose-dependent increase in ALT in a proportion of patients. It does not seem to be associated with chronic disease. If the numbers are higher, several times your lab's upper limit of normal, or your sort of defined 19 and 30 limit of normal, you probably should lower the dose and consider a second type of agent. But overall, the benefit appears to far outweigh the risk, and it shouldn't be a major concern.
Great. And Glenn, should I think of it? We talked a little bit about things like PEP, which is increasingly available. She tells me 24 ounces, 1 beer. Would a PEP help me sort out just how much alcohol is contributing to this scenario?
Probably not. I mean, you know, the question is, how much of a signal are you going to get based on how much she's drinking and when she's drinking? So someone who admits that they're drinking 24 ounces of beer a day, I'd probably say to her, look, your liver is getting injured. I need you to stop alcohol for a month and give me a pharmacologically level playing field. And then I would get the alcohol metabolites, whatever one you have available to you. The longer one's better, but it's a little harder to get. But I would get it and just see if it was 0 and her liver wasn't any better at that point after a month of not drinking, she probably is telling you the truth that she's not drinking that much, and you can press on for another reason. So I use this term with patients all the time. I say, I need a pharmacologically level playing field. Most people, when you tell them that they're drinking 30,000 milligrams of alcohol a day, and your drug that you're taking has 25 milligrams of drug in it, and 30,000 milligrams of your drug. For a month, give me a pharmacologically level playing field. If you can't stop drinking beer for a month, then you probably have to stop drinking forever. they say, oh, okay, I can do it for a month. And I see if they do it. And just see what that's what I would do.
So one thought, so you advise someone to stop drinking because their alcohol is hurting their liver, demonstrated evidence on FibroScan, et cetera, of alcohol causing damage. You touched on this, but how would that fit in your paradigm of alcohol use disorder? Someone who's persisting in a behavior that's causing documented damage.
Again, you want to see if they're an alcoholic or they just like to get a buzz on every evening, and some people really can't stop, in which case they pretty much need to stop. And I talk to them about that. I say, look, some people can't drink, and I don't know if it's hurting your liver or not, but this would give me an opportunity to see if it's hurting your liver and know what else to do. And if they can cooperate with that, they're telling you something about their alcohol use that's good. The other thing is I'd make a big fuss over them, but when they came in the next week and said, I haven't had a drink, I'd cheer for them and root them on. And the next week, if they came in, they'd gone 2 weeks, I'd buy them a Clark bar and do it like that.
So one last question. So Ken, the new drug, this beta agonist comes out. FibroScan says she's probably in that range, right? That F2 range. Should I prescribe that next week? Or you said 2 months I should be able to prescribe it. If they'll, I'm sure there'll be some prior authorizations to be done for sure for this drug. But what do you think? Someone who's got the metabolic alcohol.
Yeah, so those patients were largely screened out of these trials. So the answer is we don't know. We will learn from experience as people actually begin treating. And, according to the strict definitions that I showed you before, it's a woman with more than 20 grams, so she falls into the met-alt group. So that's D is the correct official answer. But that's a spectrum, and she's much closer to the MASLD side than not. So maybe she'll respond, and that would be worth trying.
So as we get these new medications, not tested in people with HIV, not tested in the combination met alcohol sort of syndrome, which is one of the advantages of the testing. So I'm going to wrap it up there and thank our panelists for their great talks today and their insights. And then I do have some closing remarks. I want to start by saying for our virtual attendees, you will be officially dismissed from the OPMAN 32 after this. For those of you who are here in person, you get a chance to have yet more 1-on-2 engagement with our faculty up in the round tables until about 2:30. I'll remind you the post-conference CMEC evaluations. This is for both virtual and in person. You'll get that email. Complete it the first time. That way our team won't have to keep sending it to you, and you don't have to get those email box filled up with the CME evaluations. We really do evaluate these and take your comments into consideration for next year on topics. Oh, I will say, last year someone said, update the music to something from this decade. And I think we may have failed. I remembered that during the last session. So we usually take your opinions. Music is okay too. Long-term outcomes in 2 to 3 months. So they'll follow up for the conference again by email. And then the archive, you'll be able to relive this in the comfort of your home or office in about early April, when all these recordings will be available for you to watch again, and we encourage you to take advantage of that. Express gratitude to our commercial supporters. Really helps us keep the cost of registration down, enables us to hold a meeting. We do love the in-person component. We think it's incredibly important to interact with all of you and to hear about the patients you're treating. So we thank our supporters. And here are the roundtables. So Hep C, Hep B, and metabolic-associated steatotic liver disease. Still not rolling off my tongue, but those are rooms you can ask out front where they are. And we're planning 30 minutes, and then you can rotate. And again, thank you all for attending, particularly those who attended virtually. We'll now dismiss our virtual colleagues. Enjoy the rest of your afternoon. And for those of you here, we'll see you up in the roundtables.